When it comes to peripheral arterial disease, what's interesting is most people don't even know that they have it. That's the tough part. And it's the same thing for providers. Most providers don't know that they have it, that their patients have it. And then for those that have it, a good number will have what we call atypical symptoms. Well, these are symptoms that are not classic. These are symptoms that don't fit the narrative in the textbook, but they have the process. And then we have those that develop claudication, which would be about 18% that's worsening, and at time that still get missed because either the patients don't know or the providers don't know. And then we have 1 to 2% of the folks who unfortunately will develop critical limb ischemia, which means the end stage of peripheral arterial disease. Those are the folks that present with wounds, gangrene, ulcerations, or rest pain. And unfortunately, they can progress to amputation if not addressed in a timely fashion. And addressing it requires medications. It requires opening up of the arteries and ways to do that, whether with balloons and stents like Dr. John Phillips and I can do, or with combination of surgery and ballooning and stents, or sometimes surgery alone. But it requires replenishing blood flow. And sometimes it doesn't happen in a timely fashion. We know there's some facets of the population that sometimes do not have access to care, which can lead to all these issues. So really what's important here is for all of us to get together and say, what can we do to make this better? Do we know what to do? We're still learning. And we're always going to continue to learn. But in the meantime, what can we do to make sure that everybody that we come across has access to care so we can help? But the challenge that I find is explaining exactly what this means. So I'm going to share my screen. What I want to share here is when we talk about critical limb ischemia, we know about 2 million people are facing this problem in the US, and about 25% could potentially require an amputation, and 56% will be dead within 5 years. And it's well established that disparity exists in underrepresented communities, and the multiple factors affecting this that includes conscious or unconscious bias, systemic inequalities, and imperative to improve these outcomes. This slide is really, really, really important to me. As you can see, I just want to show a comparison. When we talk about breast cancer, so every October, everything is lit up pink around the country, which is great because it means our colleagues treating breast cancer patients have done a great job of getting their message across. But when you look at our patients, so people that have Charcot foot, which happen to a lot of diabetic patients, patients with diabetic foot ulcers, and then you compare with a patient with critical limb ischemia, the mortality is much, much higher. So breast cancer over the next 5 years, approximately 11% of patients will pass away, which is not good. We still have a lot of work to do that. But when you look at patients with chronic limb ischemia, diabetic foot ulcer, or people that get major amputation, really the only thing that stands out is lung cancer. So this is the equivalent of a cancer, but we don't approach it that way. So hopefully this gives us an opportunity to empower the community, to empower our patients, so we can make sure that we're seeking the proper care for the patients facing this. Some of the issues affecting this and this outcome are social determinants of health. This is a slide that I used to present a year or so ago, courtesy of Dr. Felucia Fagarudi in Mississippi. So we have to address economic stability, so employment, income, access to good health care, and we need to make sure we address neighborhood and physical environments, so housing, transportation, parks, playground. The more active we are, the less likely we are to develop diabetes, hopefully. And if we do, hopefully we can manage it well. We know there's certain zip codes that have less access to care or to the best care. Education becomes really important. I think it's a cornerstone of what we need to do to educate the community, to educate our patients, to also educate the medical community as well on how to address this issue. And we talk about food. Somebody mentioned food earlier. I cannot stress how important it is to eat the proper diet, to eat more vegetables, to minimize processed food. But sometimes that's all people have access to. Or if you have to work 2 jobs, you might not have enough time to spend an hour or 2 in the kitchen to cook. All those things can affect that. And then we have community social context, so social integration, system support, community engagement, and then overall healthcare system. So we have a lot of work to do, and that's why it's important to have a seat at the table to make sure that we can communicate with the community to bring everybody together to improve the healthcare of everybody. And there's certain communities, certain populations that are at risk. And when you look at peripheral artery disease, we can see looking at this graph that African Americans, both male and women, have a higher risk. So it becomes incumbent upon us really to address this issue early on, to address the risk factors before people fall into that 1 to 2% population with limb ischemia facing an amputation. And guess what? This is going to get worse over time. Why? Because the population is getting older, obesity is a problem, so we anticipate diabetes is going to get worse. Unfortunately, the outcome could potentially get worse unless we as a society do decide to take an action that's different than what we've done historically. I want to share this particular slide. This is the paper that was published by our colleagues in California. They just looked at the number of people that were amputated between 2011 and 2017. 80,000 people needed a major amputation. These were non-traumatic amputations. And they broke it down by age. They looked at between 45 and 64, which is working age, and they looked at 65 and above. And you can see here, when you put it by race, so for those who are younger than 65, the risk of getting amputated, this is for whites, and this is for Hispanic, and this is for Black counterparts. You can see there's a drastic difference, 3 to 4 times higher. As you get older, same thing. This is white counterparts. We don't want to see this either because a lot of these amputations are probably unnecessary. But when you look at Blacks and Hispanics, you can see the gap. How can we fix this? When you look at the association between race and the risk of amputation or lower extremity, same thing. You can see whites here, African Americans, you can see Native Americans. This is a big gap. And these are all of us living here in the US. So we're in the same playground, but our outcomes are not the same. Now, you can look at things differently. We say, okay, let's put race on the side because sometimes it can get very sensitive. Let's just look at it by income, right? So when you start looking at income, so you have whites and non-whites, you can see the difference between amputation rate. And when you start looking at income, as your income change, you can see those with low income level have a much higher rate of amputation compared to those that have a higher income. And interestingly here, when you look at here, when you compare private insurance, those with and those without, drastic difference. So it means those that don't have access to good insurance are suffering. And how can we fix that? And then you can look at this and say, okay, let's look at this outside the US. Let's put race on the side. Let's go to a country like Scotland, fairly homogeneous. Same thing. When you look at the rate of amputation, it goes higher as your quartile of income decreases. So this is a disease of neglect. The less money you have, the less access to care you have, the likelihood your amputation is going to be higher. How can we fix this for fellow mankind? And when you look at the amputation rate within areas where high population of African Americans or underrepresented minorities, you can see amputation rate in the US, darker, that means the higher. And when you look at here, this is the largest population of African Americans in the US, and same thing in these pockets where you have this high amputation rate. So there are a lot of work we can do. One can argue, okay, maybe this is happening in rural areas. But when we look at big cities, same thing. You go to Philadelphia, you can see here, you go to Detroit, same thing. The area where you have the highest density of underrepresented minorities, that's where you have the highest area of amputation. Those are also the area you have the lowest type of insurance or the lowest income. So can we make a difference? The answer is yes, we can make a difference, but I think it's important how we approach this, how we address this issue. And when I want to look at this 1 or 2 slides last, looking at the US Census population. So as of now, if you look at adults in the US, this is the majority. We have whites here, we have Hispanics, we have Blacks, we have Asians, we have Native Americans, and multiracial. These are adults. But when you look at our children, it's different. So more than 55% of kids in America identify themselves either as minority or mixed, which is not the same as adults, which means our population, our society is changing. At a minimum, we owe it to our children to do better, because as they're getting older, we're going to have to find a way to treat them. And so as we're changing, we need to make sure that we have seats on the table. We need to make sure we have a pipeline of physicians that are going to address this issue. And if you look at clinical trials in America, so even though this is the US population of whites, right here is Hispanics, you have African Americans, you have Asians. But when you look at clinical trials, so even when we're gathering information, the information that we're gathering might not even apply to the folks that we need to treat or is reflective of our population. So there are four things we can look at: patient factors, systemic factors, provider factors, and science factors. And all of these things that we need to look at really should be centered around our patient, so we can provide a patient-centered care that's going to give the best outcome for everybody. And really, all of us need to be at the table to do this. And so the individual level, interpersonal level, institutional level, and policy level. And if we can combine all those things, we can make a difference. I just want to share the very last slide here. This is a trial I was not involved with, but we follow very, very closely. And among the things that they did that really helped was to look at the disease prevalence, understanding patient population, set up a trial that included everybody, be intentional about getting clinical sites, physicians, family involvement, so that way you can have a good outcome and a good representation. And there's another trial that we participated when I was in Louisiana before I moved to Florida. And one of the things that we did, better than we had done historically, is we had 48% of underrepresented minorities, which is usually not the case. And we also had 40% women, which is usually not the case. And I think among the many things that helped is the people that were involved in the trial. My partner, Dr. George Youssef, Dr. Samani, Dr. Punia, and myself, all of us underrepresented minorities. Between the four of us, we all spoke at a minimum 3 languages. And of all the languages that we spoke, we covered the top 5 languages spoken in Louisiana. So we're able to get access to people that perhaps historically did not get access to, and we brought them to enroll them in a trial to get information. Hopefully, they'll make it for a better future. So this is my last slide of the day. I want to share this with you, that if we can bring people on board, if we can have access to the best care, clinical trials, hopefully we can have information to make a difference among the many things I just shared with you this morning.
PAD, poor circulation in the legs, is somewhat easy to understand, but the widespread impact on people of color and the disparities in care is not. We have a renowned PAD researcher, Mary Yost, who's devoted her life to researching disparities and raise awareness about them. Her work has a profound impact on improving care for people of color with PAD, and this is why she earned the Lifetime Achievement Award from the Global PAD Association, and why we are so honored to have her here today to take a deeper dive into her passion and knowledge. Let's welcome Mary Yost. Good morning, Mary.
Sorry, I was busy listening and I had to unmute. Can you hear me?
Yes, ma'am, we can hear you.
Thank you so much, Charles, for such a very nice introduction. And also, I want to thank Charles and Kim for asking me to speak today. This lecture is based on a detailed report I published in early 2022 on PAD and African Americans. And so I'm going to talk about the Black amputation epidemic. I have about a 20-minute lecture. First of all, we have the amputation lottery. The probability of a major amputation depends on who you are and where you live. An amputation varies by age, race, sex, socioeconomic status, hospital volume, and geographic location. And Medicare and Medicaid patients are the most likely to undergo amputation, more likely than private insurance patients, and Medicaid are the most likely. So if we look at the amputation lottery in African Americans, we know that Black race independently predicts amputation, and Blacks have a higher risk for major amputation, 1 to 4 times more likely than Caucasians. And African American females are the most likely to undergo major amputation, with a risk that's 7.6 times higher than other females and a higher risk than Black males. If we look at major amputation by race, what we see is for all CLI patients, 24% undergo amputation, but 41% of Black CLI patients undergo major amputation. We look at Medicare amputees. What you see is there's a higher percentage of amputees that are Black that undergo above-knee amputations, and a higher percentage of Black females undergo amputations versus white females, 58 versus 46. Let's talk about PAD in Black Americans. If you look at the population, ages 45 and older, 12% is Black. But if you look at the PAD population in that same age group, 24% is Black. These are my numbers. And I want to talk about asymptomatic atypical disease, which I shorten as ASAT disease. I'll explain what that is in a minute. This is very important, and it's not talked about very often. If you look at a disease by severity in Blacks versus PAD in all races, what you see is that Blacks have a higher percentage of this ASAT disease, 70% versus 63%. Now, what is ASAT disease? Okay, asymptomatic disease and atypical disease are both characterized by abnormally low ABIs. The difference is asymptomatic disease does not have leg symptoms, but atypical disease has leg symptoms. They're just not intermittent claudication. And some of the most common symptoms are leg pain on exertion and rest, and leg pain with the ability to carry on walking. If we look at Blacks, let me just talk about ASAT. First of all, it's not benign. This is not a benign condition. All patients, even those who are asymptomatic, have functional impairment and decline, mobility loss, reduced leg strength, and adverse changes to nerves and muscles. So something negative is going on even in the legs of those asymptomatic patients. And ASAT patients experience a faster decline in mobility and greater mobility loss than those with intermittent claudication. Specifically, Blacks with ASAT disease have more severe disease and have a lower much poorer lower extremity function. They're more likely to lose mobility and less able to walk for 6 minutes without stopping. Now, critical limb ischemia, again, 12% of the population 45 and older is Black, but 30% of the CLI population is Black. And in African Americans, more likely to present with critical limb ischemia, and African Americans present with more severe ischemia, more likely to present with gangrene rather than ulcers or less rest pain. And gender plays a big role here. African American females have a higher percent prevalence of CLI than white females. And Blacks, both male and female, have a higher risk of being hospitalized for critical limb ischemia. Let's dig into some of the causes of the PAD disparities. Now, in my opinion, you can't just say there's one cause. There's multiple causes, and they're all interrelated. There's low knowledge and awareness of this disease and its consequences. There's discrimination. There's a higher prevalence of certain key risk factors such as diabetes, chronic kidney disease, hypertension, etc. Multiple risk factors play a role, and they have a bigger impact on Blacks than whites. Lower socioeconomic status, geographic location, and residence in distressed communities, female gender, and there are also genetic variants, although the study of that of genetics in PAD is still in very early days. So I don't have time to go into all of them, but I'm going to hit on certain key variables. So if we start with risk factors, diabetes. The prevalence of diabetes in the entire population is much higher in Blacks, 20% plus, versus the entire population, 12%. Prevalence of diabetes in those aged 65 and older, for over 47% versus 32%, and age is a key risk factor for PAD. We also have a higher prevalence of diabetes in Black PAD patients. 43% of Blacks with PAD have diabetes versus 27% of whites. And why is that important? Well, diabetes has a very significant impact on PAD severity and outcomes. Diabetics have more severe disease. They're more likely to present with ulcers and gangrene. Critical limb ischemia develops suddenly in diabetics. There are more amputations and a much higher risk, and the risk of amputation increases with the severity of diabetes measured by HbA1c, in other words, adverse blood glucose. Chronic kidney disease, another disease that's higher prevalence in Black PAD patients. 39% prevalence in Blacks versus 26% in whites. These are PAD patients. And again, chronic kidney disease has a huge impact on PAD. It's an independent risk factor for PAD, increasing the risk up to 4 times. And Blacks with CKD have a higher risk of developing PAD than whites. Risk of PAD increases with the severity of chronic kidney disease. And in CLI patients, CKD increases the risk of heart attacks and strokes and other cardiovascular events, mortality, and amputation. Now, end-stage renal disease is also much higher in Black PAD patients than white. 25% of Black PAD patients have ESRD versus 15% of whites. And again, this has a really major impact on the disease and the disease process. ESRD increases the risk of amputation. A recent study found that it increased the risk of amputation by 7 times. And the risk of amputation increases with the severity of ischemia. So if the patient has gangrene rather than intermittent claudication, there's a much higher risk for amputation. And ESRD predicts primary amputation, that is, predicts having an amputation and nothing else being done to the patient, predicts lower survival, lower limb salvage rates. Dialysis significantly increases the risk of death and major amputation. And African Americans have 2 to 4 times greater risk of ESRD than whites. And finally, this is one of the places where we do have data on genetic factors. There's an APOL1 risk variant that has been shown in African Americans to contribute to higher risk and faster disease progression to a more severe PAD. Hypertension, also more prevalent in Blacks. In the general population 18 and over, 57% of Blacks have hypertension, and whites 44%. I wasn't aware that hypertension was actually this prevalent in everybody. The prevalence of hypertension in PAD is off the charts, 94% in Black PAD patients, 82% in white. And again, same thing, hypertension increases the risk of PAD, increases the risk of PAD hospitalizations, amputations, revascularizations, and death, and also increases adverse cardiac events, heart attacks, strokes, and mortality. And I have concluded that, among other things, PAD disparities in African Americans are also gender disparities. And it turns out the female gender is strongly interrelated with the majority of PAD variables in African Americans. And Black females have a higher prevalence of PAD. They're more likely to have CLI. There's a higher prevalence of risk factors such as diabetes, chronic kidney disease, hypertension in Black women. There's also a greater impact of risk factors in females in general. For example, CKD increases the risk of PAD in females versus males. Multiple risk factors have a much greater impact in females versus males. And then finally, socioeconomic status. It's another factor. Black females, lower income, more Medicaid insurance, more poverty, greater likelihood of residence in distressed communities, and these distressed communities have a higher prevalence of cardiovascular risk factors. So another variable here, delayed diagnosis. Now, we've seen from the Euclid trial that if a patient has CLI versus a patient that does not have CLI, that increases the risk of both major and minor amputations. And even within critical limb ischemia, another study showed that 4-year amputation rates are much higher as critical limb ischemia gets more severe. So a Rutherford 4 patient with rest pain has 4-year amputation rate of 6%, But the patient with gangrene, that's Rutherford 6, has a 30% amputation rate at 4 years. And PAD diagnosis is delayed in Blacks. Now it reflects the higher prevalence of this asymptomatic disease, the atypical symptoms, misdiagnosis, and also, I think, the low awareness of PAD as a significant cause of morbidity and mortality in the non-specialist healthcare providers and also in the Black community itself. Diagnostic testing is underutilized. This is for everyone, not just by race. Between 45 and 82% of major amputations have no angiogram performed before that amputation. And unfortunately, it's been shown that an angiogram reduces the odds of a major amputation by 90%. So you're much less likely to have an amputation. It's also, diagnostic testing is also underutilized prior to minor amputation. Now the question is, are Blacks less likely to receive diagnostic testing? The data there is mixed. Some studies say yes, some studies say no. Revascularization is underutilized. Again, this is for everyone. Major amputation is frequently the first and the only therapy for critical limb ischemia. Between half and over 70% do not have a revascularization. And what we see here is, if you look at amputees, the number of revascularizations prior to the amputation by race, what you see is that one revascularization, only 24% of Blacks had one, but 32% of whites. By the time you get to 3 revascularizations, nobody had them, just about, but 2% of Blacks versus 4% of whites. Medical management is inadequate. Again, this applies to everyone. However, we know that PAD is considered a risk factor equivalent to coronary disease. And it has also been shown that, by several recent studies, have shown that less than 1/3 of the patients with PAD are treated with all 4 guideline recommended therapies. We also know that cardiovascular risk factors are undertreated in Blacks with PAD versus whites. And anti-lipids, anti-platelet statins, high-intensity statins are underutilized in Blacks versus white patients. And in particular, this is important for statins because statins have been shown to reduce the risk of major amputation. And cardiovascular risk factors are even more undertreated in women, in Black women versus white women. And again, statins underprescribed. The impact of this suboptimal medical management, one study showed that it increased the risk of amputation and or death by 8.5 times. Glucose, abnormal glucose, increases the risk of amputation, reamputation, and revascularization. And the risk of amputation and reamputation increases in a dose-response manner as glucose levels rise above normal HbA, that is HbA1c, the blood sugar levels greater than 6%. And glucose is woefully controlled in diabetic CLI, PAD CLI patients. It's inadequately controlled in 63 to 92% of these patients, and Black patients are less likely to achieve adequate glycemic control. And if you just look at an example of the poor control in Black diabetics, this is the percentage of Black diabetics with HbA1c greater than 7%. What you see is 52% of Black diabetics have abnormally high glucose versus 46% for whites. Knowledge and awareness, it's not just low, it's abysmal, and it's particularly poor in African Americans and Hispanics. The most recent 2018 AHA survey found that less than 50% of people were familiar with PAD, the leg symptoms, and the risk of amputation. And they found that Blacks and Hispanics had the lowest awareness and the greatest knowledge gaps. And in particular, only 6% were aware of the symptoms and the risk of amputation. Now, Dr. Nanu showed this version of this slide. I just want to emphasize again, this is 5-year mortality. Breast cancer, 9%. In October, you can't get away from the pink ribbons. Everybody's heard of breast cancer. 27% 5-year mortality for PAD, 60% for CLI, 77 to 85% for major amputation, but no one has heard of PAD, let alone critical limb ischemia. We also have lack of referrals and delayed referrals to specialists. One study, shockingly, of internists, nephrologists, and endocrinologists found that almost 3/4 used watchful waiting as a quote treatment for PAD, and close to 2/3 did not consider non-healing wounds a reason for specialist referral. So this was also touched on by the prior speaker. PAD is considered a disease of low socioeconomic status and high deprivation. Worldwide data has shown that socioeconomic status and high deprivation predicts hospitalizations, adverse outcomes after surgery, and major amputations. And I'll just go through some of the data on Black Americans, lower income and more poverty. Household income for Blacks, $46,000 plus versus $76,000 plus for whites. Poverty percentage by race, close to 19% for Blacks versus around 7% for whites and Asians. We also know that patients with low socioeconomic status receive less vascular care. And what's really depressing about this data is that it was just published and this stuff has not changed in 20 years or more. These were Medicare patients, furthermore, and almost 2/3 of Medicare patients who underwent an amputation did not have an angiogram or a revascularization. And low socioeconomic status patients were less likely to receive vascular care, that is either an angiogram or revascularization. And furthermore, this lack of care, low intensity care, increased the risk of mortality. So we know that health disparities vary by state, county, zip code, urban versus rural location. 80% of all disparities occur in 60% of zip codes. We also know that cardiovascular risk factors are more common in disadvantaged neighborhoods, and Blacks living in disadvantaged neighborhoods have more cardiovascular risk factors and less access to care. And in one study that looked at all the disadvantaged zip codes, what they found is that of the disadvantaged zip codes, 70% of them were Black majority versus 20% of all the zip codes in the US. And again, you've seen this slide or a version of this slide before. Basically, the highest amputation rates in different cities and around the country occur in zip codes that are majority Black. And when they looked at all the zip codes, the highest amputation rates occurred in were over 75%, where the majority were Black zip codes. So I'll just say thank you. These are the hardworking assistants. And I do want to add one thing that's, I think, very important for patients. I show this slide because my lectures are pretty depressing about amputation and all this stuff. One thing to keep in mind, family history. Nobody talks about this much, but family history increases the risk of PAD by 2 times. And the risk increases with the number of family members who have PAD. That's something to be very aware of. I don't know if we have data by racial data. There may be some more recent data on that. So
we're going to jump over to Charles. Charles, you have the first question for Mary. Go ahead and ask the question.
Thank you, Mary. Those statistics are real sobering. You gave us a lot to chew on. You seem incredibly passionate about PAD and especially the shocking statistics for people of color. What's the catalyst or the connection that you have with PAD that started your journey and the driving force for you?
Well, there's actually no simple answer, but I boiled it down. There's a number of reasons. There's a long, we could be here a half hour me trying to explain this, but I boiled it down to one key factor, and that is it's personal. Now, I don't have PAD. I don't have PAD in the family. I don't have diabetes. We don't have diabetes in the family. So why is it personal? It's personal because I identify with the mistreatment of PAD patients. And here I have to go into a little bit of my healthcare situation. My entire adult life was characterized by very negative encounters with healthcare providers. I call these providers Attila the Hun. Some were female doctors. There were nurse practitioners. There was a whole gamut of providers. And the problem was I had a painful disease starting as fairly young adult. Then even after I had surgery for this disease, there were problems with the surgery. Of course, surgery creates problems. And when I went to the doctors, my symptoms were dismissed. They were ridiculed. I was misdiagnosed, and I was told frequently that I had emotional or mental issues because I had this pain. Now, I'll inject a little humor in this. It wasn't humorous when it happened in the 70s. I saw a doctor for pain, and her prescription was that I should go home and cook my husband hot meals. So you can see why I'm a little aggressive and angry. And I can tell you this kind of thing, this kind of experience has continued. I had an experience here locally with a respiratory issue. The nurse practitioner was completely unprofessional. And again, because of that, it took me a long time to figure this out, because, you know, as a patient, you sort of bury this stuff. It's very difficult to be a patient, and particularly, you know, to advocate for yourself. And if you get, you know, if you keep being told that you have mental or emotional issues, when you know that you really have pain and there's something wrong with your body, then, you know, there's a real problem. Now, on the positive side, I will tell you, one of my positive experiences, this is a little bizarre, was when I had cancer. Now, the local folks were mixed. There were a couple of Attila the Huns here locally. But when I went to MD Anderson, which is a specialized cancer center, I had a wonderful experience. I mean, it was night and day compared to my previous experiences throughout my adult life. And I can tell you that cancer patients are almost coddled compared to other conditions. And that's good. It's as it should be. You should be treated as a serious individual who has real problems, etc. But anyway, I'm babbling on. You can tell it's personal.
Thank you. We have one of our other warriors that would like to ask you a question. Juanita?
I can't hear.
Juanita muted. Is Juanita muted?
We can actually go ahead and we can jump to Douglas. Douglas, you have a question for Mary. And Mary, I just have to thank you so much for your vulnerability. I mean, you almost brought me to tears there. I mean, so many of us can relate to just, you know, when you don't feel good and people aren't listening and there's no solution, it just is even more distressing. It exacerbates even what you're feeling in that moment. So thank you so much for sharing.
Can you hear me?
Oh, we can hear you, Juanita.
Okay. Again, I'm sorry.
Go ahead.
Again, Ms. Mary, like I said, I want to thank you so much for sharing your personal story with us, because we have so much in common when it comes to this. I want to personally thank you because you didn't have to share that with us. But my question to you is, what is the most frustrating factor when it comes to the research that you've already done, the things that you know about this disease? What is the most frustrating for you that you've gone through?
Of course, it's hard for me to ever give a simple, you know, answer. Two things. One is that, excuse me. One is that
No.
When I published the report on African Americans,
You fit that in.
it was, I knew it wasn't going to be a bestseller. But a lot of my clients are primarily industry, okay? And I sold a few reports, but there was a lot of indifference. And one client actually said, well, there's no clinical relevance. And I'm going, what? Because I didn't get into it in the lecture, but Black patients tend to have more below the knee disease, which is important. And that tends to be calcified, et cetera, which is more difficult to treat, and on and on and on. Mm-hmm. The other frustrating thing is that the numbers on PAD that are routinely, the prevalence of PAD that's routinely published were really good numbers for 1995. They're totally outdated for 2020, or we're now going to 2025, because the prevalence of diabetes has increased dramatically in the two key age groups, and the population has aged. And I finally got irritated with seeing 8 to 12 million. And I had some time earlier this year. And so I published an article in Vascular Disease Management pointing out that, you know, if you just did the math on the original numbers, the 8 to 12 million was actually never, it was just like a back of the envelope calculation. It wasn't, you know, based on a study. It was based on a study, the San Diego study, that was 800 some white upper middle class individuals, and they had some restrictive definitions of PAD. If you just took that data and applied it to today's population, it's math, it's simple. I mean, this is not calculus or anything. It would be something like, I can't remember, 18 or 19 million. And the problem is, it's not that you have to use, you know, that one has to use my numbers, but if you're going to address a problem and fix the problem, the first thing you need to do is figure out how big is the problem. And then you need to figure out what are the causes of the problem. And if you look at more, you know, contemporary numbers, the problem of PAD is bigger than the problem of coronary disease. It's about 3 times bigger. Don't quote me on this. It's several times bigger than cancer, all cancers, not just breast cancer. And it's bigger than stroke. And so, like, you know, not downgrading the numbers, having the wrong numbers is actually doing a disservice to, you know, helping get the word out and helping patients and creating awareness, et cetera, et cetera. So sorry to rant on, but.
Okay. So Mary, you have all the numbers on paper. Right now you have a virtual room filled with the faces of PAD. Do you have any questions that you haven't been able to ask an actual patient that you would like to ask?
Yeah, because I don't get involved with patients. I have 2 questions. One in particular is about leg symptoms. I have a theory. My theory is that Black patients come in and they don't describe intermittent claudication from the textbooks. They describe something else. So I'd really like to know, you know, what are the symptoms that patients have had when they've gone to the doctor? And my other question is, because I've been doing this for over 20 years and nothing much has changed. You know, how do we educate patients about this disease? I've always said, when I'm asked that question, I say Oprah, you know. So how do we change it? How do we educate patients? So either of those questions, I think, I'd be happy to know what the answer is.
I will say, for me, I knew nothing about peripheral artery disease, and I was a dialysis patient for 9 years, and until I got my kidney transplant. I learned nothing about that. I didn't even know it was it was a thing. So education would be huge, and if with today's social media and celebrities and influencers, I think that would be a great way to get the word out about PAD, because it's just not widely talked about.
But did you have any leg symptoms?
I did for years. I would walk and have pain in my legs, and we just kind of brushed it off as a long day at work or just standing too long.
Right. Because one of my doctor friends has told me that his patients, and they're primarily Black patients, describe, all kinds of symptoms that, aren't written up in the textbooks, and they have PAD. And I think I think that it's probably this atypical disease, whatever, that, I think the healthcare establishment needs to get into that area a lot more. There's only one doctor that's actually done a lot of work on that. That's McDermott. But I'm also assume that people will go with ulcers and gangrene to the doctor, and again, from the data, that gets ignored, or like the survey I said, 2/3 of the doctors that you go to will say, oh, well, it's not, we don't need to refer you to a specialist. No?
So when I went to the doctor, I complained about my pain in my legs. And the only thing that was done, there was no checks done, nothing at all. Just painkillers was given and a bottle of calcium tablets. And it was told to me, take the painkillers and take the calcium tablets every evening.
When you show up and you are having complaints, now your complaints regarding leg pain might not be related to PAD at all, which is fine. But the most important thing is we need to get to the bottom of it. If it's arthritis, we need to find out whether it's arthritis. If it's related to PAD. So it starts by just taking off your shoes. As a medical provider, I need to take your shoes off. I need to look at your feet. I need to check your pulses to see whether do you not have good pulses? And if you have good pulses, I need to move your ankle to see, do I feel any joint issues that aren't happening here? It's the equivalent of walking to somebody's house and they say, every time it rains, my house leaks. Well, you need to find out what the problem is. You just don't walk in and fix the door, meanwhile it's the roof. So we have to spend that time, as much as I had to use this analogy, when we treat people. And sometimes we just don't do that. And I think that's an issue. You brought up regarding education. We need to do a better job of educating the public at large, so the community, but also healthcare providers. Mary mentioned something very interesting, which is also heartbreaking for me. She went to doctors and said, I have a problem. And her issues were overlooked. She was even insulted by being attached to illnesses she didn't have. That's not what she went there for. Now, can you imagine if you don't have access to care? She had access to care. And those things didn't happen. So we can definitely do a better job of doing that. And another thing I like to do, what I learned from one of my professors doing my training, is I like to take things and really, really just simplify them. It helps me understand them, but it also helps my patients. Meaning, when I meet a patient that shows up in my office, I'm talking about PAD, I use analogy of plumbing, of highways. I tell them, if you walk into your house, you go to your kitchen, you turn the sink, and water's dripping. Well, we know there's either a problem with the city water coming in, the pipes aren't good, or your pipes in your house. I like to use the simplest analogy because it helps me understand what I'm talking about, but also to explain to them, because when I go to my accountant, that's what I expect from him or her, because I don't know anything about accounting, but I want somebody to break it down to me. When I have to get my house fixed, when a carpenter comes in, I don't know anything about nails, but I want he or her to explain to me so I can get it. So it is our duty to do the same thing. So if I can break it down that way.
Thank you for that. I really appreciate it, because it is something that even with my son, that was just diagnosed as a diabetic a week ago. They diagnosed him with diabetes. The doctor gave him his tablets and was said, take it at night, and that was all. No education, nothing, no referrals to a dietitian or a eating plan. And it goes to say I'm suffering with peripheral arterial disease, kidney disease, hypertension, and amputation, with pain all the time. And getting education or the awareness of the NCD side of everything is actually limited. So
Yes.
I really appreciate what you, Doctor, and Mary said. What is the other question is, what is the way forward from here
Yes.
to actually get that education out there in the layman's terms, like you were explaining now, for the plumber, the carpenter? It is beautiful. So I, as a layman, can actually understand my condition to the fullest.
Yes. No, that's a great follow-up on that question. So two things. Unfortunately, we live in a world where really the things that get attention necessarily don't deserve the attention, but they do get them. Both Mary and I emphasize on breast cancer. I have a slide that I didn't share today, and I'm glad you are from South Africa. I have a slide of the South African national cricket team, and they're wearing all pink at a game. But all of us know that the breast cancer is probably not even in the top 20 cause of death in South Africa. But they get that attention. So what we also need an advocate, whether it's a sport figure or, like Mary say, Oprah, somebody that has a platform to talk about this illness. That's one thing I think we all need. And then we also need to be unified. Unfortunately, there's a lot of fragmentation in the kind of care that we provide. Multiple societies have different ways of doing things. The care is not uniform. And so all of us coming together really makes a big deal. And it has to be a front that's all the specialists providing care. People like Mary who have the data, who understand the demographics and the impact and the magnitude of the illness, and patients, because this is what happened in the breast cancer community. You have patients, you have the families, you have healthcare providers, you have industry, you have the sporting world, all combined, and that's why they get the attention that they get. And one more thing I want to emphasize, I have three men in my life who are really important to me. One of them is my father, who lives in Canada. The other is my father-in-law, who lives near me in Florida. And the third is my uncle in northern France. Interestingly, all three men were diagnosed with prostate cancer. And interestingly, their prostate cancer were all at the exact same stage. And what's even more interesting, they were all treated the exact same way, even though they were in three different countries. You think they were treated by the same doctor. They got the same dose of radiation. They got the same medications, the same doses, all the same. What it means is that community has done a good job of coming up with a unified way of treating patients, and it didn't matter whether it was France, Canada, or United States, they got the same care. And here, Mary just presented, you go from one zip code to the other, your care changes. You are African American, your care changes. You are Hispanic, it changes. You happen to be a woman compared to a man, it changes. You show up in the emergency room of a tertiary care center,
Right.
but the doctor who happens to be on call is Dr. A. Your care is different than when you see Dr. B. It shouldn't be this. It should be the same. So we have a lot of work to do. And so maybe hopefully that answers your questions as well.
No, thanks.
Thank you.
Back
Thank you
to
for
you.
that. Thank you for that. Mary, of course, I want to thank you for your time today and giving us those statistics. If anyone wants to see more of her research, please go to www.thesagegroup.com. This is our personal plight to end racial disparities in PAD care. And we have Dr. Richard Brown and his mission to save legs and change lives. Dr. Brown is a renowned cardiologist and a senior medical executive for cardiovascular and metabolism Janssen. He will be sharing his personal connection with PAD and his efforts to drive change through Janssen's Save Legs, Change Lives campaign. In our keynote fireside chat, let's welcome Dr. Richard Brown. Dr. Brown, thank you for joining us today.
Thank you for having me. This is an extremely important topic.
Let's start with a basic question. Did you always want to be a doctor?
No, I actually, when I was in 10th grade, I was a very good piano player. So I played the keyboards, and me and three of my friends who were 11th graders, we started a band. I grew up in St. Croix in the U.S. Virgin Islands. Our band was called 17 Plus because I was 16, the other three band members were 17. And we would play music on the beach and sell food and make money. And then I got an opportunity when I was an 11th grader to be on the radio as a radio announcer at a popular radio station in St. Croix. And ultimately, what I wanted to do was I wanted to live that life for the rest of my life. I wanted to play music and be on the radio. And my mom wasn't having that. She said, absolutely not. That's not going to happen. So I was actually looking for an opportunity to delay going to college and being able to stay in the Virgin Islands longer. And Boston University had a very unique program where they allowed you to be accepted into Boston University and also Boston University School of Medicine, but you could start college at any accredited college in the U.S. or one of its territories. So I applied, got into that program, which allowed me to stay in the Virgin Islands a couple more years playing music and being on the radio. And so that is what drove me towards entering Boston University School of Medicine and becoming a physician. So it was my desire to play music and be on the radio. That's what got me into medicine.
Okay. What drew you to interventional cardiology?
So the reason that I became a cardiologist was I felt that cardiology was somewhat straightforward, meaning that people could have plumbing problems where you restore blood flow. They could have electrical problems where you speed up the heart. And cardiology is one of the most studied areas in medicine. There are so many clinical trials that tell us what is the right way to treat patients with validated evidence. And I also love the combination of being able to be with patients, take care of them, sit down in the office, get to know their family, get to know their family members, coupled with the ability to do procedures and do work with my hand. So cardiology became sort of a thing that made a lot of sense to me and my personality.
Okay. Before PAD affected your family, had you treated anyone with PAD?
Yeah, so I and it's interesting. I was looking at the statistics that Mary had on the screen, and as someone who is well read in this area, I would say a third of the statistics Mary put up today, I didn't even know. So back in the day when I was in medical school and early parts of my career, I'll be honest. If little is known now, even littler was known a couple decades ago. So I had treated patients with peripheral artery disease for sure, but not really understanding that it was a disease state that not only increases your risk of having an amputation, but it also is a marker of increased risk of stroke, increased risk of heart attack, increased risk of cardiovascular death. All those things really did not become apparent to me until it affected me on a personal level.
Okay, thank you. I've seen interviews with you, and hopefully it's not too personal, but Could you explain what it was like watching your father-in-law go through it?
Yeah, so let me explain to folks the relationship I had with my father-in-law, Russell. So I met his daughter, Lauren, um, um, right after I would graduated from high school. So here was this young dude showing up. She lived on St. Thomas, and the first encounter we ever had was I was in his house, and I was very comfortable in his home, and my feet were up on his coffee stand, and he kind of
Mm-hmm.
walked in, and he was like, "Who in the world is this young whippersnapper with his feet up on my table?" You know, and he basically said, "Next time you come into my house, if I see your feet up on my table, you will never be back here again." So that was our literal first encounter, and and so he was that sort of very direct, big spirited person. And as I got to know him, one of his dreams was he really wanted to retire in St. Thomas. He sort of, when he was at the end of his career, he dreamed of sort of going to the beach and walking on the beach and enjoying his retirement days on an island. And while I was part of his life, he became a very, very big part of mine. And my wife has two sisters. She had no brothers, so I think he kind of took me on as the son that he never had. And I developed a very close relationship with him, his wife Susan, and my sisters-in-law. The things started to unravel, and I want to give dates so that people can understand the connection between my professional life and my personal life. I finished my cardiology fellowship in 2000, and I moved to Charlotte, North Carolina, which is where I still live. So remember that date, 2000, when I finished up my training. So in the late 1990s, um, um, Lauren's father, my father-in-law, Russell, he went to the doctor, and the doctor told him that his kidney function had deteriorated. He had actually been a diabetic for a long time, was being treated by physicians in the Virgin Islands. I actually had him go up to Boston to see a kidney specialist at Brigham and Women's Hospital, where I did some of my training. And for the first time ever, he was placed on a ACE inhibitor. For the first time ever, he was placed on a statin drug. So there was a significant delay in his care that Mary touched on, just the care of his diabetes. Then things started to unravel. He rapidly developed renal failure and ended up on dialysis, and still could receive dialysis in the Virgin Islands and continued to live there and continued to be okay. But then one day he developed significant shortness of breath and some chest discomfort, and he was having a heart attack. That resulted in him being emergently transferred from St. Thomas to Atlanta, Georgia. That was the day that he left St. Thomas, and he never ever went back. So this dream of retiring in St. Thomas never ever ever happened. He gets to Atlanta, underwent a heart catheterization, and had open heart surgery. And it's interesting now. In retrospect, I look back at his care. He had open heart surgery, but still there was really no attempt to get him on aggressive medical therapy. I still feel in my heart, without question, that the care that he received in Atlanta was not the care that the governor of Georgia would have received.
Right.
He subsequently had three really bad years. First of all, his left leg one day started feeling heavy whenever he would walk, and he went to see his physician, his physician told him that he had severe circulatory problems in his leg. He had an ulcer on his leg. And again, as Mary showed, where a high percentage of patients have no diagnostic testing or an angiogram before an amputation, he fell into that category. He was told, hey, the leg has to go, and it was amputated in 2001. About 12 months later, one of his arms turned black pretty acutely. He again went to the hospital and was told the treatment is an amputation. So one of his arms was then amputated. And then about 6 months later, he had an ulcer on his other leg, which again was never really addressed, and was told that his other leg needed to be amputated. So from a very short period of time, he had 3 limbs amputated. And that was a really tough time for the family. I mean, I want you to sort of close your eyes and think about somebody with no legs and one arm. You know, I when I think about the rapid decline in his life and his health and his manhood, it really really affected me. Now, he died very soon after his last amputation. He died in 2003. And one of the things that happened in parallel to that was after he had his first amputation, we were at Crawford Long Hospital, my wife and I, and her mother and her sisters. And my wife said to me that, okay, my dad is having an amputation. Likely he'll never be able to walk properly again. So I'm going to become a runner. This was my wife telling me this in his honor. And you have to know my wife. She was not anything close to being a runner type person. Now, I didn't tell her that. And when she said it, I said, she's just upset. There's no way that's happening based on sort of her lifestyle and the way she was. But after that first amputation, she then signed up for a 3K race and trained for it and completed the 3K race. And then subsequently, she started running 5Ks and then she started running 10Ks. While she was taking on this becoming a runner journey, you know, her father died. He died in 2003. And then in 2007, our son, Ricky, was born. So Ricky was born 4 years after her dad died because of peripheral artery disease. And Lauren continued her journey of being this, you know, aggressive runner. So in 2013, so 10 years after her dad had died, she was now running marathons. And she said, this is the 10-year anniversary of my dad's death. I want to really do something to honor him. So she said, I'm going to run the Goofy Challenge. And what is the Goofy Challenge? It's something that happens in Disney World. The reason they call it the Goofy Challenge is you got to be crazy to do this. On Thursday, you run a 5K. Then on Friday, you run a 10K. Then on Saturday, you run a half marathon. And then on Sunday, you run a full marathon. So this time when she told me she was going to do that, I didn't say, well, I don't think so. I knew she could do it. So it was me, her, and Ricky. We went down there. I remember this weekend like it happened yesterday. We had a red Corolla that we had rented, and she ran her 5K, no problems. The Friday, she ran her 10K, no problems. Then she's running a half marathon, and Ricky and I are kind of following her around in this red car, and she finishes it. She's doing great. We actually go to SeaWorld, and she's just become this sort of elite type of runner. And then on the Sunday, she had the full marathon to run. So she started it and was doing extremely well. And the race started and ended at Epcot Center in Disney. And so she's back in Epcot, and she has about a mile and a half remaining to finish the marathon and finish the entire Goofy Challenge. And she came around a corner, and I was holding Ricky in my right arm, and our eyes locked. And I saw her come around the corner. She looked at me. I looked at her. I was like, wow, this is so amazing that she's going to finish this race. She explained it to me. She said, all these years I've been running, and I've been running with this anger in my, I've just been running with this anger in my heart. And I turned around that corner, and I look up and I see you holding my son. And I so desperately wish that he had met my father. And all of that was just too much. And
Wow.
that was the moment that it really, really hit me that the effect that peripheral artery disease and the peripheral artery disease related amputations had on my wife and her family.
Yeah, wow, that's powerful, Dr. Brown. We know that you said that you believe that your father-in-law received suboptimal care. If he was still here today and he walked into your office without you knowing him and knowing what you do know now, what advice would you give him, and how would you explain PAD to him?
Yeah, so a couple of things. He never went to the doctor, diabetic, and had his shoes and socks removed during a visit. Um, there was never an attempt to check his pulses and to see the degree of circulation in his legs. So the first thing I would tell him, which is what I would tell any patient who's at risk for peripheral artery disease, is, take your shoes and your socks off when you go to the doctor. Force them to examine your feet, because that is something that did not happen for him. The other thing that I would tell him is that, we have a lot of great medications to modify risk factors, etc. But diet is so critical. He grew up in, the Virgin Islands, which is a community where fried foods and sugary drinks and those types of things is very common. And quite frankly, it just I wish he knew more about proper diet and just eating healthy, and the effect that could have on his blood pressure and his cholesterol and his blood sugar levels, all that stuff. So that's something else that I would talk to him about. The other thing I would talk to him about is losing weight, because he was overweight and never really emphasized that. We know that being overweight is a risk factor for peripheral artery disease, and that would be something else I would talk to him about. And then the final thing I'd talk to him about is advocating for himself. And again, this was the early 2000s, so it might be harder for him to advocate, and I have some guilt because we didn't advocate for him at that point. But again, what I knew was very limited. But I would say, hey, don't just accept, hey, the limb has got to go as the only option. Ask about options. Ask about, are there things that could be potentially done to salvage and save my legs and my arm? And he did not advocate for himself. He just sort of took the recommendation of the physicians and did what they said.
Okay, Kim, jump in here.
Yes, we do have a question coming in from Sally. Sally, go ahead, ask your question of Dr. Brown.
Dr. Brown, my question is, you explained so beautifully everything. How would you explain to your son about his grandfather's situation, going through to inspire him to take steps to prevent it from happening to him? How would you actually explain that to your son?
Yeah, so I've actually one of the things that I do on a regular basis now is go into communities and talk to individuals in those communities about the risk factors associated with peripheral artery disease. As a matter of fact, right now I'm actually in San Francisco. I'm at the 100 Black Men of Oakland event, and after this I'm actually going to go speaking to folks about what are the risk factors, because there is such a lack of awareness about peripheral artery disease. And I've spoken to my son, I've explained to him that there's these things in your body called arteries, and sometimes you can develop plaque on the inner lining of those arteries, and that can obstruct blood flow to your brain and your heart and your legs. And so he has a good basic understanding of the pathophysiology of peripheral artery disease. But I also talked to him about things like high blood pressure and its relation to the amount of salt that you eat. And I cautioned him on that. I explained to him that his grandfather and also actually my father were diabetic, and talked to him about what diabetes is, and why he should, even though he's a teenager and all his friends are doing it, why he should be drinking non-sugary drinks and drinking things that are healthy. He has a good understanding of what cholesterol is. He's 16 years old. He's actually, had one time his cholesterol checked, and we went over the results, so he understands what high cholesterol is. And I've cautioned him because I know that as he grows up, he's going to have influence from friends to smoke and do other things, deep in the night. So I also made sure that he knows that not only does smoking increase your risk of cancer, primarily lung cancer, but it also is, it quadruples your chances of peripheral artery disease. And then I speak to him about being active, being physically active, and how important physical activity is in regards to cardiovascular and vascular health. So we've had conversations about the demise of his grandfather's health. And it's important that he recognizes as a young person that vascular disease is a decades type of process. It doesn't just happen overnight. So things that he is starting to do now as a teenager will affect his health when he's my age.
Thank you for that. Kim, on to you.
Yeah, and we do have a question coming in from Frank. Frank, what is your question for Dr. Brown?
Thanks, Kim. Hello, everyone from Chicago. Hello, Dr. Brown. You were actually featured on television in a very powerful documentary on ABC News Live. That's the streaming service for ABC. And one thing that really stood out to me is when you were honest about doctors making decisions under a so-called unconscious bias that causes them to make personal determinations. For example, that the patient would be better off after an amputation, really not considering how the patient feels about it. Now, how do we, as a community, convince these doctors that this mindset needs to change so we can save limbs? Thank you.
That's a great question. So let me just give you a personal, non-PAD related example of unconscious bias. So one of my best friends is an orthopedic surgeon, very smart guy, excellent training, one of the top orthopedic doctors in Atlanta. He's Black, and he called me up one day because his watch told him that he might be in atrial fibrillation. Turns out that he was in atrial fibrillation, and he went to see a doctor for his atrial fibrillation. And because of his risk of stroke, it was recommended that he be placed on an anticoagulant, a blood thinner. And his doctor put him on a old 60-year-old type of treatment for atrial fibrillation when there were much, much better modern options that are more expensive. And quite frankly, he called me and I was shocked that, the newer medications had been out for almost a decade. The guidelines clearly documented that those were the treatment of choice for atrial fibrillation, but yet he was put on this really old form of medication. And I know exactly what happened. It was his doctor. He saw this Black man come into his office and he was like, oh, I've seen so many Black people come into this office that can't afford their medicine, that don't take their medicine after I prescribe it because they can't afford it. So I'm going to do him a favor and I'm going to put him on this suboptimal treatment because he'll be able to afford it. And quite frankly, he could have easily afforded, the standard of care. So that's an example of unconscious bias, right? The doctor wasn't trying to harm my friend, but because of all the biases and the lived experiences that he's had as a person or as a physician, he made a decision to give him something that was suboptimal. And the same thing is happening without question in the management of peripheral artery disease. I work at Johnson & Johnson now, and we've developed a tool called the heat map, where we look at Medicare patients, so all patients with the same type of insurance. And so, this is not a comparison of someone with Medicaid versus someone with Aetna. All have the same type of insurance. And there are areas in our country, lots of them in the Southeast, where the rate of amputation in people of color is significantly higher than others. And a big driver of that has to do with doctors just, again, making this decision. Maybe this patient is not going to be able to show up 3 or 4 times for follow-up care and all the complications that go with, a PAD patient. So let me do this patient a favor and just finish it off right now and do the amputation and move on to the next problem. So one of the things that is so critical is this recognition and us spreading the word about unconscious bias in medical care. Doctors feel that we treat everyone the same, and we feel that we try to provide the best care to everyone. And fundamentally, those are true statements. But quite frankly, we all are filled with biases. I think back to walking down the wards in the hospital, and I've thought of times where, I'm in a room, it's a white family with grandpa and grandma in the room and brothers and sisters, and I see myself sitting down in a chair and taking out a piece of paper and a pen and drawing diagrams and really explaining the disease and the options. And then I could go 2 doors down, and it's a Black person who is by themselves and doesn't really understand things. And I basically say, hey, this is what we're doing, without a level of explanation. And again, I'm a Black person, and I know that I've done things like that. It is just raising awareness, that making physicians know that even though their intentions are good, we often make decisions in regards to patients' care where our own biases creep in, and sometimes that leads to a recommendation for something that's suboptimal.
It's so interesting you say that. I want to jump in just because one of the catalysts for me really getting involved in the PAD fight is one of my experiences at a Louisiana hospital where I was watching cases. This man was amazing with his hands. Some of the most complex cases, he was just finessing, right through the blockages, restoring blood flow is great. I said I wanted to interview him at the end of the day. He said, hold on, I'm going to take you to clinic with me and then we'll do the interview. In clinic, I remember the last case of the day, this African-American gentleman walked in. He was hobbling with a cane. And he looked actually about 85. I mean, he was only 50. He just really looked age, and like he'd been through so much. And I was just heartbroken. But I looked up at the screen and I saw the imaging, and I was like, oh, this should be easy. The doctor had more complex cases earlier today. This should be good news for this gentleman. But to my surprise, he said, I'm so sorry, sir. It's time. We've unblocked it a few times. And you know, I think that we need to amputate. The man burst into tears. I couldn't legally say anything. He walked out the door, and I asked the doctor, I don't understand why. You had more complex cases earlier. And this will, I can quote him because it rings in my ears. And he said, he's just a poor man, black man from the projects. He smokes, he drinks, he won't take care of himself, he won't walk. So why delay the inevitable? And in that moment, my entire life changed. And I felt like God was speaking to me. And I'm almost tearing up here. And I said, Doctor, you mark my words. You will not be amputating anymore on my watch. And I walked out and I started the Way to My Heart, which is now the global, PAD Association. Wow, I've never it's emotional during my thing. I'm going to turn it over to, I'm sorry, I promised Charles I wasn't going to cry.
I'm in tears. I'm in tears because everything that you mentioned, everything that you said, I experienced in my journey to where I am now. When this all started, I was here in Maryland. I'm just going to give you a small piece. When this all started, I was living here in Maryland, and these doctors, my primary care physician, the orthopedic surgeon, I visited them every day, and this started out as a small mosquito bite. It started out looking like a bump, a small mosquito bump. And every week or so, I would go to the doctor and say, it's changing. So then it went from looking like a mosquito bite to it looking like a flat with pulse underneath, just flat. And then I got my first amputation because they waited until my toes were black. I mean, black to the point of no return black. That's when they amputated my toes, and they didn't tell me why, but they just said that they needed to be amputated at that point. So it's a lot of the things that you said in your story that resonates with me so deeply.
Dr. Brown, can we talk a little bit about the work that you're doing now with Janssen, the Save Legs Change Lives, especially the Empower van? I think that thing is really cool, and it can do a lot of good. What can we expect from that program and the van in 2024, and how can we get involved?
Yeah, because
Yeah.
it's so important because, channeling, it sounds like not only your purpose and your passion, but also that of your wife and literally continuing that fight, for your father-in-law every single day. I'm sure he's right there, with you both in mind and spirit.
Yeah, so in 2020, we all know the world was kind of falling apart. COVID was ravaging the world, and it was interesting. In October of 2020, I saw a special on TV, and what it talked about was it talked about the fact that Blacks were dying from COVID at up to 3 times the rate of whites. And I was like, that hit me. I was like, that's weird. Why same virus? Why would there be a racial disparity in regards to um, um, COVID deaths in this country? And then in November of 2020, the then CEO of Johnson & Johnson, a gentleman named Alex Gorski, announced that J&J was going to be making a $100 million commitment for something called Our Race to Health Equity, and an attempt to reduce health disparities, across the world. And that's when I started thinking about my father-in-law again. And I was like, wait a minute, he had peripheral artery disease, and his outcomes was likely worsened by the fact that he was a man of color. So I started to pay attention to this. That's when I actually first saw writings from Mary Yost, and I started to recognize that, wow, this is a big problem. And that gave me the impetus to join Johnson and Johnson. So I became part of the team at J&J in the summer of 2021. I came there and I met some really amazing people who also cared about health disparities. We formed a cardiovascular health equity task force, and then we picked as our North Star, how can we reduce the rate of PAD-related amputations in Black Americans? And we started this initiative called Save Legs, Change Lives that was announced at the American College of Cardiology meeting in 2022. And this initiative, Save Legs, Change Lives, has 3 pillars. So the first pillar has to do with research and a scientific approach to PAD-related disparities. So we're digging into data and showing that these disparities exist. We're going to physicians and talking to them with our heat map about, why people of color are having less revascularization procedures and more amputations. We're currently working on a publication because people say, well, the reason that Blacks do worse is because they show up with more severe disease, and ultimately, what can the doctor do? But we're actually going to publish a paper where we took data from the Society of Vascular Surgeons database, and we normalized it. We had people with the same severity of disease, and you'll see that Blacks, even starting at the same starting point that whites, they do worse. So there's a sort of research and scientific component to Save Legs, Change Lives. The second part of the second pillar has to do with us connecting and working with partners. So partners like Kim and her organization. We've partnered with the American College of Cardiology because we believe that concordant care, meaning people are receiving care from people who look like them, increases the likelihood that they will be compliant with medical recommendations and improve their outcomes. So the American College of Cardiology has a program that we are supporting called Change the Field, and it's attempting to increase the number of female, Black, and Hispanic cardiologists in America so that there's more of us to care for these patients. We've worked with many other organizations and continue to do work with other organizations and our governmental affairs partners to try to push forward legislation that would allow for ABI screening for high-risk individuals. And then the third pillar of Save Legs, Change Lives has to be being in the community and raising awareness and detecting disease earlier. So we have faculty members. First of all, it was all Black faculty members. We have now expanded Save Legs, Change Lives to also focus on the Hispanic community because their numbers are also poor. And faculty members go into communities and at a 5th grade level, talk to individuals in those communities about what is peripheral artery disease. There's pictures of arteries and what plaque looks like. And we go through all the risk factors and testing and all the things that will empower these individuals that when they're in front of their doctors, they know the right questions to ask and they know how to advocate for themselves. And then the other piece of our empowering communities pillar of Save Legs, Change Lives is we have 2 mobile units that go out into the community and do what we call ankle brachial index testing, where you check the blood pressure in the arms and compare it to the blood pressure around the ankles. Those should be the same. But as you develop peripheral artery disease, the blood pressure around your ankle starts to fall. So this is a way to detect earlier someone who is developing peripheral artery disease. A test I wish that my father-in-law, someone had recommended that for him. I think it could have significantly changed the course of his medical journey. And we're, going through multiple communities with these mobile units and providing ABI testing for free, so that individuals can have their PAD hopefully detected earlier, get on a walking program, get on appropriate medical therapy earlier, and hopefully reduce their risk of having a PAD-related amputation. I feel very fortunate to be at J&J, and leadership there supports these efforts. I have a tremendous team. My health equity director, Dr. Jillian Stevens, she's actually on this call, and my associate director, Chris Ewan, is actually here in San Francisco with me. And there are so many other people in the community. Carla Rideau, who's in Houston. So many people at J&J have really gotten behind this effort. One thing I should point out is that one of the places we were in screening was Houston, Texas, where we showed up with our mobile units and we did this ABI testing on individuals in that community. And 41% of the individuals in Houston had an abnormal ankle brachial index test, which means that 40% of these patients very likely have reduced blood flow in their legs and aren't even aware of it. And these are the same people that will show up in an ER at 2 a.m. and with critical limb ischemia, and as Mary showed you, have a very high chance of having that leg amputated before they're discharged from the hospital. So we have a website. I encourage everyone to go to it and send it to other friends, www.savelegschangelives.com. Spread the word. PAD has a PR problem. Enough people don't know about it. More people need to be aware of it. Individuals, patients, doctors, legislators. So the Save Legs, Change Lives initiative is all about raising awareness, early detection, changing legislation, scientific exploration to shine a light on this, and partnering with other organizations that care about this very, very important health disparity.
Thank you. Thank you. Douglas, you have a question?
Real quick. Yes, sir. Where are you finding the most resistance from? What side of the table? Where do you find the most resistance from today in making those changes that y'all working on?
So a couple of things. Number one, I'll give you a perfect example. We had that ABC News Live special, and there's a video of it out there, and a friend of mine sent it to some doctors who he knows. And what he told me was he got a lot of pushback from a couple vascular surgeons that he sent, where they felt, oh my gosh, this ABC special was all about race and playing the race card, and really and truly, let's be honest, Black people don't take care of themselves, and let's not blame the physicians for what's going on, whatever. So there is a certain amount of ignorance around people feel that it's all on the patient showing up late in the disease. And again, I am not saying that there's a responsibility of the patient to take care of themselves and to do the right thing in regards to their health, but so many are unaware on the patient side, but also physicians also have to take on some responsibility for this disparity. The other thing that I should point out is that from a hospital system, and my main job at J&J is to interface with health systems and improve their care of patients. But we have gone to health systems and chief medical officers and directors of vascular surgery, et cetera, and talked to them about these disparities. We've talked to them about why reducing the rate of amputation in their hospital is the right thing to do and why it's better patient care. But what we also recognized was one of the areas of resistance is the economics of PAD care. And what I mean by that is an amputation, patient gets rolled into an operating room. It's a 40-minute operation. They're sutured up, they're done. The hospital gets paid a DRG, and they're on to the next case. Peripheral revascularization procedures can sometimes be very lengthy. Sometimes they can be 4, 5, 6 hours. That's a very long procedure for one DRG payment. So there is sort of a thought that, well, it might actually be economically better to have an amputation performed and just move on to the next patient. Now, we are in the middle of putting together a presentation in collaboration actually with Mary Yost that shines a light on the economics of this. And what I just said is absolutely wrong. It's actually, to a health system, much more expensive to do an amputation because of the complications associated with an amputation, infection of the wound, now back in the hospital needing treatment, higher risk of cardiovascular, poor outcome, ICU stay because of an amputation, patients falling, and beyond just the economics, we felt that we needed to create that narrative to talk to health systems and not only tell them from a medical standpoint, reducing your rate of amputations is the right thing to do. From an ethical standpoint, doing that is the right thing to do. But we also feel that we needed to arm ourselves with an economic story so that they understand that there's cost savings to the health systems also by reducing their rates of amputations.
And we wanted to jump over. Dr. Zola and Dandu had a quick comment as well. He wanted to chime in.
I really want to thank Dr. Brown for sharing your personal story. But, when you share a personal story, somebody might say, well, that's only a one-off story. But then you bring up the whole perspective of the data and everything that's associated with this, and the hard work that you're doing traveling around the country, trying to make this better. So it's a very, very big deal. So I want to share two things. Can you hear me okay still?
Yes.
Yes.
Okay, very good. So the one thing I want to share is a story about unconscious bias, and then I'll talk about something else regarding proper foot care. So I took care of a patient once who started a journey at another hospital. And while she was there, she lost her left leg, and she's depressed, everything you can imagine. This is a woman that was sophisticated, but that's her demise at that time. And while she was in a hospital, she developed an ulcer on the right foot. So she can foresee what the future will be like because she already lost the left leg and she's struggling with that. And she was taken to the angiogram suite. They attempted to open up the arteries to the right foot, but could not. So after the procedure, the team came and spoke with her, and the physician spoke with her. And they told her that we couldn't open up your arteries. So she looked at the main physician and asked the physician, said, Doctor, I just lost my left leg and I have a wound on the right. And you just told me that you could not open my arteries. So that means more than likely I'll lose my right leg too. And the doctor looked at her and says, strong possibility you will. And so the patient looked at him and asked, do you know anybody that can help to open my arteries so I don't lose my right leg, just like I lost the left? And the doctor looked at her in the face and says, no, good luck. So that's her story, that you're probably going to have to come back and get amputated, but good luck. So she goes home, depressed, crying the whole time. and goes to her podiatrist. And her podiatrist sees her and talks to her. She tells the story. And the podiatrist says, well, I know somebody that can potentially help. How about you go see him? So she comes and sees, not necessarily me, but our team. We sit down, look at everything. We say we can try to help. And she's really stoic and quiet, just looking at me. I explain what we're going to do. She's looking at me. And then she asked me, but Dr. Such and Such couldn't open it. How come you think you can? I said, well, I remember our conversation before we started all of this. You told me that you had been praying so hard for your arteries to be open. I cannot guarantee you that I can open your arteries, but I want you to keep on praying as you have been for yourself, but for me and my team, so we get to succeed. So we take her in, we open her up, we fix all her arteries, and everything goes well. So at the end of the case, I go to speak with her after she's awake and chatting with her. I explain everything that we did. I use the Doppler, pulses are loud. She says, doctor, does the other doctor that took care of me knows the work, knows who you are? I says, yes. Does he know the work that you do? I say, yes. So how come when I asked him, he told me he didn't know anybody and good luck? I said, I cannot answer that question. Now, going back to unconscious bias, this person is a good person. But at that moment, didn't realize that he offers suboptimal care to that patient. Not being able to treat the patient didn't mean that that patient care ended there. He or she could have gotten the phone and called somebody else. And so when you love somebody, that's my takeaway from this. When you love somebody, when you look at somebody as yours, as your equal, as your mother, as your uncle, as your father, you do what's best for them. Meaning you get on the phone, you call others, you seek what's best. But when you don't have that in you, we talk about empathy, sympathy, compassion, then these are the things that happen. Now, this woman, you can say, okay, she wasn't poor, she was educated, she had transportation, she had everything that she needed. But at that moment, what that extra help she needed was not given to her. So that's a good example of unconscious bias. That physician didn't realize at that moment that they let this patient down. We treated her and she's fine. She walks with a prosthetic. Her right leg was never compromised. And unfortunately, she lost her left leg. So that's one example.
Yes.
And I want to go to what Dr. Brown mentioned earlier regarding things that could have been told to his father-in-law. One of the things that I usually do as I see patients that come with PAD, everybody shoes and socks are off. And among the many things I've learned from my podiatry colleagues is I always ask them 3 or 4 questions regarding proper foot care. Among other, I'll ask, who's your podiatrist? Who takes care of you? I make sure they have one. Number 2, I always ask them, do you ever walk barefooted? And I'll ask them, who clips your toenails? And if they ever say, it's me, immediately I tell them, you're fired. You can't do that. Tell them they have to see a podiatrist to make sure that they have somebody who's professionally trained who can take care of their feet. Just having a podiatrist decreases your rate of amputation. When it comes to proper foot care, I'll tell them, you might think because your house is paid off that you know your house that well. The reality is you don't. And nobody wakes up in the morning planning that today I'm going to walk and hit my baseboard, but it's going to happen. So if you have PAD, any injury can lead to CLI, gangrene, and then all the bad things happening. So it's really, really important for proper foot care. So I tell every patient to make sure that they never walk barefooted, always wear shoes, see a podiatrist, and then me as a cardiologist, then I make sure that we address all the cardiovascular risk factors. I go crazy when I have patients who smoke. I put every bit of effort to help them through that journey. It's not that you need to go home and quit smoking. I enroll them in smoking cessation programs so that way we have a good success of becoming smoke-free and to remain in remission of tobacco exposure. So these are the things that we're doing, in a small scale, but hopefully if there are 10,000 of us doing this kind of work, if we have 10,000 of the Dr. Brown around, of the Mary Yosts, hopefully we can make a difference. Thank you very much for your attention.
Absolutely. Thank you, Dr. Ndandu, for that. And thank you, Dr. Brown. For Dr. Brown, I have a final question for you. You and Dr. Ndandu have both touched on it. We've went over it a lot in our planning sessions that there's a lot of mistrust in the healthcare system, and it's been that way for many generations in our community. Was it like that for you in your household? And was it ever a factor in your decision to become a doctor? And do you still have these concerns today?
I absolutely still have these concerns, and that is why I'm a really big believer in concordant care. I really feel that, and this has been shown in the maternity literature quite clearly, right? That if a Black pregnant woman is cared for by someone that looks like her, infant mortality goes down. So I'm a big believer in sort of having people that look like each other taking care of each other, taking care of the patient. I think that goes a long way towards this barrier of mistrust. The second thing I also think is important, though, is education of patients, because we have many examples where patients just don't trust what is being recommended to them. My wife is actually a gastroenterologist, and she battles with patients not being as interested in a screening colonoscopy because they've said things from we think that you might be leaving behind some kind of tracking device, and or we feel that this is experimentation. So there's also an element where patients need to also be educated that, there are things that are historical that might make a person of color feel that they should not trust the healthcare system. But the vast majority of physicians, regardless of the color of their skin, have good intention. And a removal of this barrier in regards to mistrust really should be front and center in our minds, because it is an impediment to equitable care.
And I do have a very special guest as well that's here today. We have legendary Harlem Globetrotter Larry Shorty Coleman, who has been waiting to talk to you, Dr. Brown, and sharing his experience as well, because he can certainly share from experience that there is, a generational and cultural and historical, mistrust even in his family. Shorty, do you want to go ahead and jump in and say hello to Dr. Brown? And go ahead and share your experience as well.
Yes, good evening to everyone. And Dr. Brown, thank you very much for sharing. And thank you, Kim, for making this possible for us to share this during Black History Month or any other month. I am the legendary Harlem Globetrotter Larry Shorty Coleman, no better than anyone else. But with the experience I had to go through, seeing my mother through diabetic lose her leg, I said, there's no way in the world a guy like me that's running down the court, running my mouth 24/7, this is going to happen to me. But you never know what God has in store. But anyway, that did happen. And I suffered I believe it's in 2020, I had felt like I had a cramp. I felt like I had pain in my calf. Believe it or not, I was being stubborn. And I said, I'm not even going to go to a doctor. I'm just going to rub it, ice it, put heat on it. It got worse. And I went to emergency. Believe it or not, everything you guys are saying on this podcast, it came to light just listening to you. Unfortunately, I went to emergency, and first thing they did was go get an amputated doctor. I had no idea whether I was African American, white, yellow, or blue. He said, "Oh, sir, we're going to have to amputate that leg." And I looked at him like, if you think you taking my leg, and knowing I got a lot of more work to do, running, jumping, and walking. So I left the emergency on my own, and about another week or two, pain got very excruciating. So I went back. I had that doctor come in again, and he said, "Well, I'm going to have to admit you." He admitted me, then he came into the room 15 minutes later. "Well, I think I'll have to schedule surgery in about 15 minutes. He don't know. I'm used to people getting called for 3 seconds being in the lane, but no way are we going to surgery without me speaking to at least 5 to 6 more doctors, which I did. However, they said that doctor shouldn't have told you that. Well, anyway, he did. But come to find out, the other doctors say, "Well, we're going to try this, we're going to try that." I felt like I was an ingredient. They was just mixing things to me, and I'm not going to say I'm not educated enough to understand what they were saying, but I've never had this type of injury and never had anybody tell me about it. And fortunately, I had 8 operations, not 2, 8. Taking graft, putting the stents, doing this, doing that. All right, where do I go from now? COVID was going on at the time. I had no family members there to communicate with besides on the phone. One particular evening while I was in the hospital, I got the worst pain in the world in my left lower leg. And you talking about crying and boo-hooing. So I told the lady that I needed pain medicine. I was already on every pain medicine that you could name. And I said, I am used to taking Tylenol or aspirin. Even though we're saying this, I asked for the doctor to come in. I said, "Okay, just remove this leg." Well, he lowered the lower part of my leg. You talking about a gentleman that's been playing sports from 11 years old to 62. I lost my mind. I lost respect for whoever was in the room after the fact they had removed it. It was devastating to me, but something tapped me on the shoulder, which is always the good Lord, if for those of you that believe it. He said, "I'm going to make you stronger than ever through this." He did. And however, today, I'm still going teaching kids how to be positive through sports and how to learn how to walk with the prosthetic once again. Since 2020 now, I'm having a very hard time. I'm not young anymore. And it's very difficult because the disease, PAD, has traveled to my other leg. Make a long story short, I'm not going to give up, and I hope I can encourage others to be enthusiastic as I am. And most of all, don't say you can't do it. Just keep trying to do it. Like me and Kim say with Weight of My Heart, one step away from being the next step. So now pass it on to my family members. I have a nephew that lost 2 lower legs at a young age. My oldest brother lost half his foot. My uncle lost a leg at 70, 80. And we must spread this. And I'm glad you guys are having this type of podcast. And I thank you very much for having me. And God bless.
But Larry, thank you so much for sharing. But you were mentioning, and we've talked about your nephew and some of your other family members, and you reached out to us to help you save your other leg. Why is it that your other family members are so resistant to help and they continue to say yes to amputation? Why are they letting this happen?
I think they're letting it happen because of the fact they're not listening to what I'm telling them, because I'm not a doctor, but I am their relative. So I don't understand why they won't let me have them call you, who advise me to a great doctor, as well as the great doctors you have on the panel, Dr. Red. Now I'm with Dr. Dre Diploma, who's another great guy who helped saving my leg. And I'm doing the best part, going to therapy and doing on my own and keep the blood flowing as best as possible. But again, with my relatives, it's a thing called being stubborn. And that's something majority of us as African Americans do when it comes to doctors and going to the hospital.
Yes, why is that? What is your understanding? What goes on in the conversations from generation to generation that has led to this mindset?
I think that it just basically comes from being stubborn and seeing older people growing up that you take for granted. They're old. That's why it happened to them. And you get fixated with that in your mind. And that's not a good thing to do. But I'm going to continue to tell them, you don't have to have your leg amputated. You don't have to have your piggies gone. You can do something different. It's 2024. Wake up and smell the coffee.
No, that's very important. Kim, can I add one or two things here?
Yes.
It goes back to a couple of things Dr. Brown mentioned. When you have physicians who also, or patient look like the physician or vice versa, I think it goes a long way. So I can use one example here. As I mentioned earlier, I am originally from the Democratic Republic of Congo. Born in the US, grew up there, so my formative years were spent there. And Congo, for those of you that don't know, Central Africa, it's a former Belgian colony, population of about 100 million. That's how many people are there. There's not a single angiogram suite. So if you have critical ischemia, you just lose your leg. So because of all of that, currently in the Congo, when somebody has critical ischemia, has gangrene, people really think of it as an illness that somebody put on you. So here in America, we say somebody put voodoo on you, juju, jazz, whatever you want to call it. So here I am practicing in the US, and this is what I do all day long. And so when I get international consults or when I travel to Congo, it's a lot of work having to explain to people that what you have, it's not because somebody has done something that, intentionally against you, is because you have poor circulation that we can work on. But to be able to do that and to break those barriers, it takes time, it takes energy, and going back to what I mentioned earlier, it takes empathy, sympathy, compassion, and also a fundamental understanding of who you're dealing with. The fact that I grew up there and I understand the cultural nuances, when I have these discussions, I know how to navigate through these waters to help the folks understand. And so some of the things that happen here is you have patients who come in contact with physicians, and even before the physician walks in, he or she, there's already a mistrust. And so those barriers have to be broken. And that's effort on both sides. So really, it will take everybody to put effort to break down these barriers, to increase the pipeline of physicians that can respond to these needs, so that way we get to address these issues. Because if we have technology available, and the only reason why it's not making it to save these limbs is mistrust, well, we need to work on that. If we didn't have the technology, that's a different story, but we have it. So that's where we have to put our effort, and hopefully we get to do that. Thank you.
And I also like to jump in and say, if more doctors were like you all on our podcast right now, and our family that's been sharing with way to my heart, is such a mega dollar that a amputated doctor makes, because I only go by that from when I get my summary from my insurance. I think that plays a big part. I don't want to step on no one's toes or make them feel bad, but it's a big business.
It is a big business. It's a huge business, and it's getting even more bigger. Let me tell you why it's getting larger. We, as peripheral artery disease patients, warriors, we were put on the side burner because there was nothing that they could gain from us at that particular time. Now we are considered the hot commodity in healthcare, in trying to solve the situation. Therefore, the great doctors that have been out there fighting this fight with us, along with us, and for us, are being pushed out by greed. How do you go about giving your patient? You want your patients to have the reassurance that you're going to help them through, regardless of what they're going through. But if you feel as though you're just a number, you're just a file, you can't even get an eye-to-eye contact conversation going. What's the point of me trying to be there, getting resolve from you when you're not, I'm seeing you're not going to help me. You're just going to take another piece of me. And when every time you take a piece of me, I grieve that piece that has been taken. I grieve because that piece that I was born into this world with is gone. And now I got more medications I have to take. I got more medical issues I have to deal with. And you can go on your yacht and chill. You know what I'm saying? That's stressful.
Very much so.
For you to put, for doctors to put us in such a shell, in such a cave, to whereas they only want to pull us out when we're the it thing. Cancer has been the it thing forever. The color pink, yes. The it thing forever. Why can't we have that same it thing? Because just because it's Black History Month and we're talking about this, Black History Month, for us, this is an everyday occurrence. This is a wake up, go to sleep. This is a how am I walking today? Am I walking straight or not? Am I moving differently to where people can notice that I don't have part of my body that I was born into? There's a lot of trust issues. But when I first meet my doctors, I trust that they're going to give me the information that I need in order to educate myself better about my condition. Therefore, going to another doctor, I'll be able to explain to them in layman's terms what I just learned from the doctor I had before. We don't get that. We get, you might have poor circulation, but look, they're purple now. They're Black now. We got to cut it off. We're still going to be a liability because now you've cut it off. I still got to come and see you. You still got to help me heal. I still got to have all these different medications. It's a lot that we go through that after you cut it off, it's over. It's done. How do you have patients deal with that?
And Thea, your daughter is actually jumping in the chat. I'm not sure if she wants to unmute really quickly, but she's talking about the fact that fear and mistrust are related. And I'm curious, with your experiences, how that's also leading to the next generation of fear and mistrust, and her ultimately maybe not getting diagnosed soon enough, only at the point where amputation becomes the only option. That's scary. That's really scary to think about, that it just, this domino effect keeps going and going and going.
But that's my point, Kim, is what I'm trying to say is they had plenty of time. We had time. It was a mosquito bite. You understand? We had time. I was going to all my visits. They was doing everything but what they were supposed to do. I found out about Doppler by going to Michigan and then coming back and saying, oh, you got to start doing this, because that's what they did to me in Michigan. But whenever I come back here, the first and only thing they want to talk about is amputation. They don't understand. I'm willing to have this fight. I'm willing to go through all of these things in order to have a quality of life that I deserve.
Right. And when you stand up to speak your mind, what happens? You get silenced.
They silenced me. I went on YouTube telling my story, showing my videos, letting them know what I was going through, what I was experiencing. And the first thing they want to call me is an angry Black woman. No, I'm not an angry Black woman. I'm pissed off because I'm trying to explain to you what's going on with me. I need you to understand that I have learned to listen to my body, and I need you to listen to me. But yes, you're the doctor, but we can teach each other. It's not just what you say goes, because I know a couple of things now that I didn't know at the beginning of this journey. And I'm still willing to fight every fight that I need to fight. But I need people around me, my team, to be ready to fight with me.
Thank you so much. And we have Felicia that might want to jump.
Yes. Thank you, everyone. I thank all the doctors and everyone that's come on. It's so helpful. It's disheartening. My son passed away last year, and he had he had a small cut between his big toe and his other one. And, we put some stuff on it and put a Band-Aid on it. And as we, you go to the doctor, they clipped his toenails, and then it had gotten just a little pus on it, I guess. And the doctor said, no problem. He just said, what do you call that stuff? Betadine. And then it got worse, and we called the doctor. We need to come in on an emergency. And he said betadine. No, we betadine that until he lost his toes. And it was only like 2 toes, but the doctor wanted to cut off all his toes because he was trying to save them all. And then the situation went to it was left foot, then the right foot. And it was every time we were asking, why is this going on? We never, ever got a test for PADS until we met Dr. Ansari. And Dr. Ansari was able to put stents in his legs. He was on dialysis for 12 years. And we never got a conversation from them. Been going to the foot doctor. He'd been cutting his toenails. We don't cut them. I am so angry because I lost my son because of all of this unnecessary. Doctors don't explain. Every time they say it wasn't all diabetes. It wasn't all diabetes. It was something that could have been taken care of, but they chose to tell us. By the time I got researched everything, I think he had already lost a few toes. But, Dr. Ansari saved his legs. But then he had a heart issue that from dialysis that we didn't know about. The heart doctor didn't see it. He took the test. Gary had a heart attack. They say, well, he's fine. I'm like, okay. So we meet Dr. Ansari. Dr. Ansari took some other tests. And then he sent us to a different doctor. And that doctor gave us the news of our life, the surgery that had to be done. It was just unending. Then after the heart surgery,
after the heart surgery, that was one of the hardest moments because I lost touch with Felicia and I kept thinking something's wrong. And I kept messaging and she finally called me and she said, I'm so sorry, I've been out of touch. I have to make the hardest decision of my life.
Yeah, and I kept telling you, I had to take him off life support. And then Gary woke up and it's like, wait a minute, Gary says he want to do everything he can to
But before
live.
they did that, they said they wanted to take you off.
Yeah.
And I said, not on my watch. They're not pulling the plug. And I said, you need to call Dr. Ansari now. And Dr. Athar Ansari ended up calling that hospital and said, have you even done standard protocol and even tested to see if he has any sort of brain waves? And he did. And within 24 hours, right?
They moved him.
Woke up.
Yeah. Wide awake.
And they were going to take him off life support.
Right. I mean, the head of the department, the head of the hospital coming down and telling me I'm doing the worst thing ever to not take him off. I'm ruining his life. I'm making him suffer. And I mean, I cried for weeks. And I refused to let them do it. And they pressured me from the nurse to the doctor, every single doctor. And I thought it was cruel. It was just cruel. We ended up going to a convalescent, I think. And he had a huge bed sore that was astronomical. But I like to say that, you know, Gary woke up and he woke up really well, and he was lively and talking for about 3 months. And we don't know what happened at all. But I can tell you that there was not enough nurses to keep him clean. There wasn't enough doctor care through his whole entire time.
Whoops, we are having a little bit of issue with Charles.
Even going back to when he was first diagnosed, he was about 5 years old when they said he could become a diabetic, you know. And it was just not the care. When it was like back in the time when your parents had medical insurance, but if your kid didn't go to college, then they became off. But Gary was diabetic. But so we had to go to this thing, I forget the name of it, and that's how he would get his medicine, and to a point where they wouldn't give him his medicine. And it was just a fight to get the medicine. So Gary was 18 years old. He did, like, if I'm going to die, I might as well live my life. And so we went through a lot of changes medically, and I can tell you it's just never got explained, never got tested the way it needed to be, not even going through dialysis, not even fighting the doctor. And the more we said that something was wrong, even for my own self, I've had to fight for pain issues. And so they come up with this thing, fibromyalgia. But, you know, so it was hard. It was very hard. And I'm here to fight for people at any, you know, where I hear it, to tell them about it so that they don't have to. I didn't know he didn't have to get his toes amputated. I didn't know he could have took tests to find out whether his artery was clogged. I didn't know he didn't even get a stent put in to open up those. It could have happened way when he got the little cut. They could have sent him to get his legs checked. They didn't.
Dr. Brown, I see you shaking your head. You want to jump in here? It's really disconcerting, isn't it?
Well, two things. First of all, I have a question for Larry. Larry, when you presented with your the pain in your legs and went to the ER the first time, was that the first time you had pain, or did you have chronic discomfort in your leg that was coming on whenever you walked?
It was the first time I felt that pain, and it continued. That was the first time I've ever experienced it, even through playing sport.
Yeah, the point I want, 2 points I want to make. Well, first of all, Kim, thank you so much for including me in this very, very important discussion. But the first point I want to make is that if you go down the street and you grab 100 people and you say to all 100, have you ever heard about something called a heart attack? I guarantee you 98 of them will say, of course I have. If I pick another 100 people and I say, have you ever heard of something called a stroke? 98 or 99 of them will be like, of course, I know exactly what a stroke is. If you then find another 100 people and say, have you ever heard of peripheral artery disease? I'd be surprised if 40 of them say, yep, I know what that is. I recognize that name. So one of the biggest challenge we have is, quite frankly, raising awareness. And folks on this call, really and truly spread the word any way you can, because we definitely have an awareness problem. The second thing to Larry's presentation is, sounds like he presented with clinical limb ischemia. And a high percentage, almost 40% of patients with peripheral artery disease, obstructive peripheral artery disease, actually don't have symptoms. Either they don't have symptoms or they have atypical symptoms. You know,
right.
They have things like, wow, I'm losing hair on my legs, or my legs feel cold at night, or they feel heavy, or I'm feeling numbness. Mm-hmm. It must be a nerve issue from my diabetes, and lots of atypical symptoms or lack of symptoms in a high percentage of patients. That creates a medical problem because, because again, lack of symptoms leads to lack of diagnosis, which is why being examined by your doctor and having your feet examined is so important. That allows for earlier detection of peripheral artery disease. And the second thing is be on the lookout for efforts by different groups and organizations to allow for screening in high-risk individuals for peripheral artery disease. The American Heart Association and the American College of Cardiology a few years ago published a statement where they felt that in high-risk individuals, we should be screening just like we screen for breast cancer in women over 40, or we screen for colon cancer in people over the age of 45. We don't have a mechanism to screen for peripheral artery disease in higher risk individuals. So when you hear of efforts to get that done, support it. Talk to your legislatures in your community. That is also a very big missing piece to this dilemma that we're experiencing. I feel very moved by lots of the discussions today, and I would like to thank you, Kim, for giving a damn, for caring, for trying to mobilize people to make a difference in the lives of individuals. Thank you so much.
Thank you, Dr. Brown. The mistrust in the healthcare system. I just want to give a few historical facts that may add to the mistrust. The Tuskegee syphilis study conducted between 1932 and 1972. The study itself was just unethical, as its participants were not informed of the nature of the experiment and were denied proper treatment even after penicillin had become available as a cure. At least 100 men died, and numerous wives and children were affected by this travesty that was funded by the U.S. government. Just another example, Dr. Marion Sims, he was also called the father of gynecology until recently. He conducted gynecological experiments on primarily enslaved women in the 1940s. He operated on multiple women during his research, and Sims performed his gynecological experiments without using anesthesia. The women on whom he operated on endured excruciating pain without the benefit of anesthesia that was available, and it still believed, he believed that Black people could tolerate a higher threshold of pain, and that's something that we deal with to this day. We have a dozen people of color ready to share their stories in about this 40-minute session. Weigh in the comments if on social media, if you want to add to this conversation. We can start with the general fear of going to the doctor and where it stems from. For me, just growing up, going to the doctor was when you had something severely wrong with you, or what your parents deemed that was severely wrong with you. For colds and cuts and things like that, we would always have some home remedy, a hot toddy for a cold, or just Vicks salve for a stuffy nose and things like that. And it wasn't until I got older that I realized that it was not just a financial reason why we didn't go to the doctor. It was actually mistrust from all of the things that were passed down from my parents' parents, from their parents, about exactly like the Tuskegee and Dr. Sims that were using us as experiments. I know through our planning session that other warriors had the same experience. Juanita, you want to jump in?
Yeah, sure. As far as feeling like a guinea pig, as far as fighting for the right to just exist as a PAD patient, getting misdiagnosed, not getting diagnosed at all, paying for travel to go out of town for care that I should have been able to get in state. My story is so long and so vast with a lot of different flips and turns in it. Right now, I would just like to hear from someone else and share their story.
John and Amy are here, husband and wife, and they have been fighting for John's legs. I'm curious if you want to weigh in on Charles' question about how, fears and mistrust that you may have grown up with in your household based on what you've heard from your elders have influenced, your mindset when it comes to healthcare, and then ultimately then your experience yourself with the next generation. John?
Well, Kim, how you doing? I just want to share what the other guy said. When I was growing up, going to the doctor to me or going to the hospital was like death, like you was gonna die. If you went to the hospital, because every time that any family member of mine went to the hospital, chances of them coming out of the hospital was slim. They didn't come out. Growing up. That's how I experienced, going to the doctor. That's why most Black people don't want to go to the doctor, because they know when they go there, they may not come out. That was my experience. My dad, he was diagnosed with lung cancer at 45. Okay, he didn't go get chemo. He didn't do none of it. When they said this is what you had, he continued to work. He didn't go get no kind of treatment, and he lasted until he was like 62 is when he died from that. But he didn't get no chemo. He didn't get anything. But during that time, he knew all along that he had cancer, but he still didn't go to the doctor. And he wasn't surprised when we found out that this is what he had, and and he was ready to go get treatment for it. He didn't seem upset at all, because he knew what he had, and and that was that. So just that everybody on the panel who's had this experience of going to the doctor, I had the same experience, the same thing with my limbs my toes being cut off the same way. It was just fear. It was fear, and not being told the truth. Fear, and not when they see me, they just say, okay, he Black, he's been working this long, he smokes and he does this, he does that. And that's how they treated me. Everything went accordingly. Okay, you got one toe going to be cut off, and now here's your leg. It just went like that until we met Kim. Till God brought us to her. That's the reason why I'm standing right now. That's the reason why my legs. Why I'm keeping my leg, because otherwise I probably wouldn't have. I don't. It's just right now. It's just scary to think of. Not only me, but other people going through the same thing, and they're not knowledgeable. All this knowledge I got today about all this was about Black people. I didn't know. All I knew is when I was growing up, not if you was Black, or not to go there, not to go to the hospital.
Mm-hmm.
So that's the way I associated the hospital with with being going there, being Black, And here, like I said, in 2022 is when I started going to the hospital, and when they started treating me just that same way. I told the doctor, I said, "Listen, I quit smoking, I quit this." He didn't believe none of that. Okay, then he just took it as he just didn't. They didn't trick. They told me the same thing. After they figured out that they couldn't open up one of my limbs, they said, "Okay, you're not a candidate for nothing else. You can't, and leave." They just left it at that. They just left me just out there. No referrals to somebody else that they knew, and it was a person in the surrounding town that could have did it, but they never, nothing.
Growing up in the South, we have this thing about we don't go to the hospital because for decades, for generations, our ancestors didn't trust, and they came from a place of we make homemade salves, we rub stuff on, we bandage it up for a couple of days, and then you're fine. We didn't talk about diabetes. They said, stuff like, oh, you have sugar. We didn't know what sugar was. We just thought we were sweet like that. We got sugar. Okay. But when we found out people were, being amputated left and right, we still didn't understand, because all we still heard was, oh, they had sugar. We didn't know anything about diabetes until we got up into our teens and adulthood, and until I was diagnosed with it. I would see family members with amputations, and that's the first thing that would come to mind. And then it was, oh, it's just diabetes, not understanding that these amputations was happening more so because of peripheral artery disease than anything. But to us, growing up in the South, in the country, without, many resources, you had one doctor in the town over, and he primarily dealt with the white community. And if you came in, he was shocked to see you, and he wants to get you out of his office really quick. Those are the type things that we grew up, as Black Americans. We didn't have the wherewithal to say we want a second opinion. Because they didn't want to see us anyway. We don't want to ask too many questions. We just want to get out of there. Okay, you've seen us, we gotta go, because we're already untrusting and knowing it. You're not gonna do the things you did for my grandmother. You're not gonna do for Miss Sally over there. Miss Sally is gonna get the best care. Whatever we can do to fight this, we're gonna fight it. Where my grandmother, she had pancreatic cancer. She died from cancer. But the treatments that they gave someone else other than my grandmother, I know it was inadequate. I know that. So yeah, we grew up fearing doctors for more than one reason. We've had a lot of family members went in and never came out, and we never knew why.
Yeah.
So it's a lot of different reasons for us. And in order to build that trust, it's difficult. It's very difficult. So when we let you into our circle, you're in. When we say you're family. So for you to break that is devastating for us.
Ms. Juanita, I want to add something to what you just said, which is very, very important. Talking about trust. And this is what I mentioned earlier, Dr. Brown also mentioned earlier. So this is why it becomes really, really important, and Charles mentioned that earlier as well, to have a seat at the table. Meaning, if we have a large number of physicians, Blacks, Hispanics, participating in the care of these patients, who also have an understanding of the cultural background, then it becomes easier to break down some of these barriers. Now, I'm going to share a perfect example. Talk about barriers. So I mentioned multiple times, I grew up in Congo. It's a place very much like the Mr. John just mentioned, where there's no trust. So in Congo, most people go to the physician when something's wrong. So if you ran your knee against the wall, you're in pain, you go look for a physician. But sitting at home, blood pressure 180, it's not giving you any trouble, but we know it will. And so that's why it becomes important to really educate the community to take away these barriers, so that way we don't wait for those last minutes, because by then the clock has been ticking for a long time and we're in trouble. So early checkups, early detection, early treatment, but we want people that will deliver the care in a way you feel cared for.
Exactly.
Meaning that experience when you walk into a doctor's office and you feel like he or she wants to leave as quickly as possible, you walk out that office with more questions than answers.
Exactly.
That's very difficult. For me, I'm very lucky, man. I just grew up in a big, gigantic family, and I'm just used to that many people. So not uncommonly, I'm hugging my patients. Some of them don't even call me by my name. They just call me baby, honey. I look like their grandkids. I look like their nephews that they left at home. And so all those things really make a difference. And when I sit down and say, please, you have to take aspirin, you have to take this medicine, they understand, because there's that special bond. And it's not easy. My mother, an educated woman, and I am her son, and her father My grandfather was also my best friend, a medical professional. It took me nearly 5 years to convince my mother to take medication for hypertension. She had hypertension, but every day she had a reason to not, because culturally, you just don't take medications every day. But I had to convince her, and now she is. Now, I could have also said, well, forget it. Why am I going to waste my time doing this? And she, who knows, all these years, she'd have had a stroke by now, something like that. But she's okay. But it took effort on my part. I made it a point to not take care of her. I made it a point to have somebody else take care of her so I can be on the sideline, but knowing that they're going to give her good care. Now, there's nowhere in the world she ran out of medicines. She makes sure she has it all and she's doing very well. Like I said, she's an educated woman, but she grew up in a country where people just don't take medications every day for no reason, in a sense. Why am I taking something for hypertension when it's not giving me any trouble? But we know what's going to happen. Same thing with diabetes. Early on, it might not give you any trouble. But if we don't spend the effort and the time to educate the community at large, we're always going to be having these issues towards the end when people are high risk and losing their limbs. So we need to reach to our children. We need to go to the community. We need to reach out to people with open hearts and explain things to people so people can understand. Because if you just want to check the box and say, oh, by the way, smoking does this, that's not enough. You have to sit down, you have to talk to people. And that's how we're going to make a change. So it's really important to really come with our hearts and love and affection to really get these messages across to make a difference. Without it, I think it's extremely difficult. So that's what I want to share in that regard.
I agree. I agree with you, doctor. I really do agree with you. We all have to open up our hearts. And this is our way of doing it, by educating and trying to reach out to others that don't understand what's going on with their bodies, to be able to, you know, answer or ask the questions that need to be asked.
Or even just understanding where the patient is coming from. I took care of a gentleman a couple of years ago, 63, divorced, and he lived at home with his parents. And he was the sole caretaker for elderly father and elderly mother. So when I saw him, I was more motivated to take care of him, not because of him, but because of his parents.
Yeah.
And I just knew deep inside of me that if this man goes, automatically those two other parents are also gone. So that was my motivation. But I could have easily just said, oh, you have PAD, and that's the end of that. But the extra 30 minutes I spoke with him, whatever, I was able to find out how meaningful his health was and how much it meant to the rest of his family. So him getting amputated would have affected him in a very negative manner. And so, but that was extra 30 seconds or so that I spoke with him to get that information. So when you do that, it allows you to go the extra mile for folks to really help them.
Well, you know, I think one of the big issues is location. You know, a lot of people in certain areas of the country and outside of the country, you know, because of where they live, the cultural background of where they live, they do have a lot of bona fide fears, and those fears are usually based on misinformation or knowledge. We tend to fear things we don't know, we don't understand. And that in itself will keep a lot of people from going to the doctor, going to hospitals. And unfortunately, you know, even the least little thing that happens, sometimes if you don't go to the doctor promptly, you know, can lead to a very serious situation. And so, you know, we are left with, how do we get the information out? How do we let people know what's going on before it happens to them? Fortunately, my father was in the military, so we did travel around a lot. But also in being in the military, I was exposed to a lot of different types of culture, a vast variety of types of people. And I didn't have so much of the trepidation about going to doctors and hospitals, but I still had my leg amputated. And a lot of that I feel is, you know, and I felt like I was being treated right by the doctors. They were doing everything they could, but the atmosphere of, you know, going to a doctor and having it in my mind, I know this is going to be bad. I know I'm not going to make it out of this hospital. And that's something that a lot of people have lived with all of their lives, that type of culture. And it's nobody's fault, but I feel also that a lot of people need to take responsibility for themselves. You know, a lot of times when people go to the doctor, they do whatever the doctor says because they have been taught that doctors go to college, they know all of this information, they must know what they're talking about. And that's not always the case. Hello?
In terms of the experiences that you've had and in losing your leg, you have kids as well, and seeing what you've gone through, what is the conversation that you have with your kid to stop the cycle and to make sure that they don't have fears of going to the doctor and that they do get to the doctor sooner rather than later?
Well, you know, I think mostly it's a lifestyle. You know, my kids know that I go to the doctor if I need to go to the doctor. And I haven't foreseen, I have one daughter who is a special needs. And, you know, in having that type of openness in our family, knowing that it is not as scary a place as sometimes people have been told. And I have never generated that type of atmosphere. And that in itself lends to them being more comfortable in going to the doctor and seeing a specialist or whatever the case may need.
Right. Thank you, Rodney. And I know that we have Judith Taylor, who is still on and hasn't been able to jump in as of yet. Judith, what really, you know, in your experience, and in your ancestry and with your parents and grandparents, what were the conversations like about the healthcare system, and how did that impact how they live their lives and their care?
I was blessed with parents who were both teachers. And so education has always been important, and awareness. But even with them, my father died when he was 38, as did everyone in his family, from cardiovascular disease. It was just assumed that this was the way it was. I watched my father have heart attacks often during my childhood. My mother didn't drive, and we had to wait for other people to help us get there because cabs didn't come into our neighborhood. That was not an option. So he sat there and waited until we could rouse someone who could come and spend the hours at the VA to get him seen. Meanwhile, in my own healthcare, my podiatrist, as a diabetic, looked at my feet all the time, but no primary care doctor. It turned out I had gout, and he referred me to his wife, who was a primary care doctor. So I had educated care, but no one saw the PAD. They saw the diabetes and assumed it was neuropathy. So for 10
So true.
Yeah.
Yeah. And it woke me up at night, the whole deal. I did what they basically lived with it. And finally, I got a different insurance that allowed me not to wait for pre-authorizations. And I went out there and found somebody who tested me with and said, yeah, you got no pulse in your toe. And finally, they were going to do surgery without checking pulses or anything, without going through what really is happening. And thank God I was blessed to find Kim. The day before they were going to put a stent from my shoulder all the way through, as Douglas Salisbury has experienced, I found Kim.
Right, the axillobifemoral bypass.
Yes, I was so grateful. And I was spared that. Now, I've had 3 surgeries trying to clean out. I have a fem-fem and a fem-pop that my current doctor said should not have been done. And I'm scheduled on the 23rd to go through another surgery to revascularize. But thank God somebody is looking at it. And it took my research, and thank God for the internet. I never would have gotten in touch with Kim. And still, they do not realize how this is still affecting my life. I mean, I'm still waking up at night, etc. The network of PAD has been life-saving in terms of knowing what other people are going through, and I've been talking to other people in my world, and they too have never heard of PAD. One of the things that I would like to see is CMEs being required to teach this, required to do this as part of professional life. They will not see it. They will not put the emphasis, because even these doctors that are working with us before did not know the prevalence. So we've got to really aggressively promote this for all doctors, not just people who are specialists. And the other thing that I think would be important, Kim had a wonderful idea about, how they do the walks for cancer and all that other stuff. We need to be doing that for PAD, especially because walking is so important in building collaterals, even through walking through the pain. People don't understand that when that pain comes and you stop walking, you're doing yourself a disservice. So we need to get the word out. We have been blessed with permission by the internationally known Ricky Byers. She was married to Ricky Byers Beckwith. She was married to Michael Beckwith. But it's Rickie Byers, Byers. She has a song, Walk, Walk, Walk Like Somebody. Walk, walk, walk like you love somebody too. And she's given us permission to use that song as part of our awareness campaign. If we could have somebody who, and you all who speak with health systems and publicists, we need someone who can help us full-time get the word out to the public. And if we start grassroots as well as working with the organizations, we would be able to get this as known as the pink and all of that for the other things. We really need an aggressive public education campaign, because I have doctors who respect my intelligence, but they didn't see it. They didn't see that this was not neuropathy. They didn't understand that this keeping me up at night for 10 years was not just, well, live with it. So we all have to talk to the people with us, and those of you who are working with institutions. If we could join together and really be public with this, it would make a big difference.
I agree.
Can I jump in real quick?
Sure. Just I want to comment really quick on just what she was saying in terms of the walking and Ricky Byers, that we do have an initiative, and it's Prayer Walk for PAD, and we're hoping to create a day of prayer walk for PAD. And hopefully, maybe we can include Ricky Byers, and we can expand it to congregations across the country, which I think would be incredibly powerful. And maybe we can get Pastor Judith Taylor over here to actually lead the charge in working with the DEI team to execute on that.
I would love that. I would love that.
Could I jump in
Mary.
and make a comment? A couple of comments. There's a real theme here with the patient's stories, and it's diabetes, it's sugar, it's diabetic foot ulcers, and in terms of the reality is none of this stuff exists by itself. For example, 60 to 70% or more of critical limb ischemia patients have diabetes. And if you look at diabetic foot ulcers, if you look at that population, it's not just neuropathy. In fact, neuropathy by itself is a minor cause, one of the smaller causes. The vast majority, like 50, 70% or more of diabetic foot ulcers have critical limb ischemia. And I don't know if the doctors don't know this. I know that maybe 10 years or more ago, you would frequently see in the literature that, oh, all diabetic foot ulcers are neuropathic. Well, they aren't. It's totally wrong. Now, whether the doctors don't know that or they don't tell the patients, I don't know. And my final comment about, and this is about minor amputations. This goes back to some comments that were made earlier. And again, there's the theme here. Nobody was tested before they had the minor amputation. I've given lectures, I've written some stuff on this. Minor amputations are just as bad as major amputations in terms of the consequences and the causes. But one of the key things is if you don't test the patient, you don't see what kind of circulation they have, you can cut off a toe, it won't heal. You cut off another toe, it won't heal because it's not getting adequate blood flow. So if they never test the patient, they're going to just keep cutting things off needlessly and just creating, and it costs a ton of money to the healthcare system. It also, not to mention the terrible cost to the patient in terms of the emotional and psychological and the physical costs. And in fact, it was in one of my slides, I didn't emphasize it, but there's even way less diagnostic testing of any kind, where I'm not even talking angiograms. Any kind of diagnostic testing is massively underutilized prior to minor amputations. But there is this sort of thing out there, this idea amongst doctors that, oh, minor amputations, they're just minor, and it's okay if we do minor amputations. And it's not okay. It's just as bad, if not worse, than cutting off the leg.
Yeah, there's no, I'm sorry, as far as amputation is concerned, there is not even, amputation is amputation. It's gone. A part of your body is gone. There is no, I don't even understand that terminology. To me, it's offensive because a body part is a body part. If you was born in this world with it, you should have it at any cost. And for doctors to know this, but still put you through it instead of fighting with you to find a better solution, they really just cut it off. And to me, that's brutal.
I really want to get into something else that's cultural, especially in our community of color, that I know I dealt with this in my family and I still do, that we are people of faith and we will believe and believe. And I know a lot of people that are going through health challenges and they say I'm just going to pray about it and won't go to the doctor. And I believe that God has healing power, but you also have to do something on your part.
Exactly.
You have to do the footwork.
Exactly.
Absolutely. So how do we reach those people that are just, I'm just going to pray about it? How do we get to them to a point that, yes, faith is great and faith goes a long way in healing, but you also need to go to the doctor also?
That's a great one. So I grew up in that family. We went to church every Sunday. We went to Wednesday Bible study, Friday afternoon Bible study. As a matter of fact, when I was in second grade, I was in the Bible league, that we called it, and I used to sit with the elders of the church, reading the Bible with them. So I know exactly what that means. And even in my own family, right? People would say, "Oh, I'm just going to pray about it and not go to the doctor." So for me, it's simple. Like when I talk with my family members, and I always ask them, "How long have you known me?" Right? You've known me since I was a kid. You helped raise me as parents and aunts and uncles. Don't you think that perhaps the knowledge that I have, that God could have contributed for me to be who I am? And so I think when we meet people who are very, faith-based, who would put aside medical treatment, I think it's important, it's incumbent upon us when we have these discussions to explain that, yes, faith is important. I've asked patients to pray for me, to pray for my team, to make sure that what we're going to do is going to be successful.
Yes.
But we have to be practical as well, meaning if we think that teachers and doctors and preachers and pastors are a venue that God utilizes to get things done on earth, then physicians are also within that same category. So I think it's important when we meet people of faith to make sure we have these open discussions and say, it's great to pray, but God also has given us this knowledge to do A, B, C, and D. And instead of using one in separation, we can use both together for good outcomes. I've had patients who've asked me and their families to pray before a procedure. To me, there's nothing more powerful than that. And so I think there's plenty of room to work with folks like that. But I think the challenge comes in is when you come across a person of faith that say, oh, I'm just going to pray about it and not do anything else. And we turn around and walk away from them. Because I think they're still seeking answers. And another thing that I've done personally, especially the many years I spent in Louisiana, is every time I came across a faith leader, a preacher, a pastor, priests, deacons, I will treat them. And at the end, I will always ask them as a favor, when they stand in front of the community talking to people, to just spend the extra 3 or 4 minutes to talk with the congregation, to let them know that they need to go to the doctor. And then when they go to the doctor, they have to ask for their numbers, blood pressure, heart rate, cholesterol, diabetes, all those kind of things as a favor, because those preachers came to me as patients with cardiovascular issues. And I always remind them that the people that you face every Sunday have the same problems that you have. So is there a way you can just take away 3 minutes from the sermon and tell them that they all need to go to the doctors? They need to quit smoking. And a lot of it, I appreciate it because they never thought about it that way, that because they're in a position of authority. So I think as we talk about educating the community, as we talk about educating the nation, as we talk about starting a grassroots movement, these are among the things that we need to do. We need to reach out to those faith leaders who have access to the community and let them know about the things they can do to make things better for our community in general. And so we should embrace those folks and little by little trying to make those changes as we approach them. And like I mentioned earlier, with open hearts.
Thank you. Rodney, were you trying to get in?
One of the things that, I'm 66 years old. I had my leg amputated about 5.5 years ago. And when I first went to the doctor because I was having pain in my legs to where I couldn't do my job correctly, I went to the doctor and they did all kinds of tests and this and that. And then after like 3 or 4 appointments, they said to me, you have PAD, you have peripheral artery disease. I'm a fairly educated guy. I grew up in a very educated, motivational family. My father was a minister, by the way. And I had never heard of peripheral artery disease. I had no idea what it was. So in me going to the doctors in that capacity, when they started telling me, well, you have this, you need to do this, you need to do that, I almost slipped into the mode, well, he's the doctor, he knows what he's talking about. But for whatever reason, I decided to go to another doctor. And this doctor had totally different opinions on what I should do. And, well, the common themes are, quit smoking. But to have that vast of opinions on actually how to treat PAD was so stifling. And I feel like, the doctors are in that position, I'm not going to say all doctors have this God complex. You know, a lot of doctors have that, the ego. A lot of doctors have that type of atmosphere that they've been to school, they know what to do, when in actuality, there is no further training for a lot of doctors as far as PAD symptoms, what to do, how to alleviate those symptoms. I spent 7 years, in total agony because nobody knew what to do. And, you know, it's just a question of education, education, education. You watch TV, watch a movie on TV, and during that 2-hour span, you will see at least 15 commercials about diabetes, about heart problems, about this, about that. I have never seen any educational information about PAD.
You're
and
absolutely.
That just leaves, just leaves the
correct.
population totally vulnerable.
Yeah, you're correct. And in our next section, we're going to talk a little bit about the black foot deception. It's bad enough when we struggle ourselves with understanding our symptoms, and it's even worse when the doctors don't understand our symptoms.